European Commission, and we have NABA, JCIS, all are, working towards it. And they have produced a lot of strategic documents, conducted a lot of studies, produced evidence-based guidelines, initiated programs of action, and, they have galvanized the support of political and health workers basically to work towards the patient safety. And this has led to remarkable transformation in the way that patient safety is viewed. With that, I would like to introduce the moderator of the session, the most renowned Dr. Malti. She's the Chief Medical and Quality Officer at Aster DM Healthcare. She is responsible for implementing quality protocols and standards across the DM healthcare verticals such as hospitals, medical centers, and pharmacy, both national and international. Welcome you, ma'am. I would, request ma'am to take the session forward and introduce our renowned speakers. Thank you very much.
So, good afternoon, all of you. I think we've just probably at 12 now. Yeah, please. So, thank you for this opportunity. I think from yesterday we have been talking a lot about patient safety from various perspectives. Today's topic is from a public perspective, or called as public entity. And we are going to see how public institutions also play a very, very important role. You've had a number of sessions where various hospitals have put forth safety, and today we are going to have something which is all about the public entity. And joining me on this particular session, we have our panelists. So we have panelists who are stellars, are very well known in their own fields of safety, implementing quality, and they come from very renowned institutions. So with me, I have Dr. Arvind. He's the professor and head department of neuroradiology. He's also the deputy medical superintendent at NIMHANS. I'm sure all of you have heard the name of NIMHANS, very, very common to everybody here. And he drives digital technology. Thank you very much for joining, Dr. Arvind. You can come. Thank you. We also have Dr. Atul Kochar. Atul Kochar, I think, is a person whose name is become a name in every home, wherever we have people from healthcare, and he's the CEO of NABH, instrumental in driving quality against all our hospitals. So we owe a lot to the organization. So proud that you lead such a prestigious organization. And we have with us Dr. Mrs. Shishta Nadu Basu. She's a senior director and head, Department of Obstetric and Gynecology, another very, very well-known hospital, the Max Super Speciality Hospital, Shalimar Bagh, Delhi. She's a member of the governing body of the National Board of Examination and Medical Sciences of Government of India, New Delhi. So we are going to also have perspectives from an educational aspects on patient safety. So she comes with us with a lot of information on that aspect, and she's also the national chairperson on the communication in healthcare and professional development. Needless to say, we have been talking even yesterday, a lot of our diagnosis, which we talked about clinicians, we said 3 aspects of it are very, very important on the accuracy of diagnosis, timeliness of diagnosis, but very important, how we achieve safety is communication. Because in a healthcare delivery system, it's very complex, it is very dynamic, because it involves doctors, nurses, paramedics, support staff, and there are many areas where you can go wrong. So diagnosis itself, which is the responsibility of care, can go wrong just because communications may not be effective. So we are going to listen also about communication perspective. Now, let me just introduce this topic, please, ma'am. So, what is this topic today going to be about when we talk about the public entity? The first and foremost, patient safety. Now, all of us, I'm sure, will agree, patient safety is like a fundamental right. Every person globally has a right to having quality of care. That is why today it's very important that all of us are talking about safety, because it's a right for a patient to get the right care at the right time, and that means it has to be safe. And that is why we are going to look at safety, and the simple way to understand safety. What is the safety all about? Safety is, simple terms, unnecessary harm should not be caused. because a patient is coming because he believes in you, he believes the care that has been provided. And if you see in general, patient when they complain, they have only one word to say, and that what they say is, we never expected this to happen in the organization. That means that expectation was, I trusted you. And this is what you did, because I trusted, I came that I've got a fracture and you're going to treat me. But what I landed up is an infection from the hospital, a hospital acquired infection. He said, why did I have to go through that? So that is why we say unnecessary harm. Accessibility of care, affordability of care, efficiency of care, people-centeredness. We have been talking about this from yesterday in various sessions, saying this is necessary. We're going to look at how do public hospitals try to enforce these practices, and there have been simple strategies are required. Every time we think implementing safety is going to be a lot of money, it costs a lot, it could be some simple practices, just hand hygiene itself can bring it down. So how are we going to implement that, which is what is important, because we will be surprised that in every 100 patients, 7 of them, even in developed countries, have hospital-acquired infection. And in the developing countries, the number is every 10 in 100 patients get this infection. More than 300 million surgeries are done, and we are finding that even 50% of them have complications. Some get reported, some do not get reported, because everybody believes it's a stigma. And that is why we have to understand this session today is all about patient safety should be aligned with the national goals. Next slide, please. So before we start, I just thought to begin this, I'll tell you where are we now. What is the current status in India before my esteemed speakers will start taking up their respective questions. There are laws and regulation. In our country, we should accept that in the healthcare, there are laws and regulations, but sometimes what we see is it is not uniform. It is fragmented and it is in silos. Some have got everything done very well. Some of them are learning to do that, and some of them probably are yet to begin. So that is some sort of a scenario. We have a Clinical Establishment Act, which is very well enforced, and what does it talks about? Patient rights. We have this act going on, but far and wide, is there everybody knows about the patient right? The patient has a right to ask the clinician or tell the clinician, I do not want to continue the care under you. Has a right to say that I want a second opinion. So that is what, is it available at all places? We have an excellent National Health System Resource Center, which is very well known. I'm sure all of you know there is something called NHSRC, and it is responsible for quality assurance. So it is not that the picture in our country is dismal. We have it all. The only question that we have to answer today is how much is it? Where are we? And how long do we take to reach our goal? And that's what is going to be today. Therefore, what is the need? Everywhere it is in silos. Can we consolidate it across all our hospitals and centers? And now, friends, this is a task force which has been implemented, which is actually what is called as the National Patient Safety Implementation Framework. This is what exists right now, and as we go along, we will talk about this steering framework, which is putting a lot of efforts to implement patient safety across the entire organization. Next one, please. And therefore, we will talk about this goal, and we will talk about some aspects which are already known. A lot of corporates, private hospitals, which have gone in for national, international accreditation. But friends, that's a small proportion in our country. The need of the hour is our public entities, because majority of our population rely on the public hospital, the government hospitals, which is very, very important. And accreditations, even international, they go for the JCI. How many of our hospitals, the smaller hospitals, smaller nursing homes, where actually our needy people go, can they even afford an accreditation? So does it mean we compromise safety for them? The atomic board, which makes sure that your radiation doses are fine, We have got such boards. There is a pollution board which is looking at your biomedical waste management. So that's again by the government. And all of you should know that the government has an extreme, very sophisticated mechanism of identifying adverse drug events. And whenever there have been such, there is a pharmacovigilance. A very good monitoring system, but unfortunately, a lot of our monitoring data is about deaths. It's about maternal death. It is about neonatal death. They focus a lot on those, but time has come to shift and see there are many other parameters in a small way that we ought to measure. So which these words, which I said, which is the crux of our problem that is existing, or rather I shouldn't say it's a problem, I would put it as it's a concern. It's an area, probably what I say is an opportunity, a need for an improvement. Let's look at and see our esteemed panelists for today. As I said, who come from an accreditation, CEO is here, who's going to tell us about what he thinks about accreditation to all our hospitals. We have Dr. Arvind, who comes from a premier institute, who's going to talk about the public at large and what does he believe is the future for it. And we have a clinician who's going to look at it from a clinical perspective and say, what do clinicians face across our hospitals, including the public hospitals, and how communication is a global issue. So with that in mind, we'll try to have about 3 rounds, and each one of the speakers will take about 3 to 4 minutes, and in their best way, try to put forth based upon the questions that I have. So let me begin with Dr. Arvind. Thank you first for joining. Thank you very, very much. A very, very important aspect that I would want to look at from yourself is I would like to know from you, Dr. Arvind, about what is your opinion and you think about the current scenario coming from public institutions across our country. What is the scenario as far as patient safety is concerned, and what is the status? Thank you.
So before this session, I want to make one announcement. We'll have a question for the audience, and whoever gives the best answer based on the panel they'll be deciding, will have a gift hamper. So please be attentive through the session. Thank you.
Thank you, ma'am. From the public health perspective, I should take this question, what is the current scenario based on our experience, what NIMANS was prior to 2016. Because I will tell the reason in the subsequent this one. Prior to that, ours was the premier institute in the neuroscience and the psychiatry care. But still there are lacunae which we could make out in the subsequent years. Though we had a wonderful recording system, there were lacunae in that. And even the people who are working in, they were of the view that whatever they are practicing is to the topmost healthcare. And the reporting pattern means whatever the audit that we need to do, it is all driven by the data. That data part, if you ask, there is no standardized way of data collection. So to audit ourselves, these are all very important, and audit is one of the main crux for making ourselves to improve upon what we were yesterday. The same scenario exists across the various public health hospitals right now. They range from the PHCs, primary health centers, urban health centers, medical colleges at the district level, at the state level. If you go wherever in those hospitals, if you ask these certain questions right now, there is no standardized answer, where there is no standardization that is followed for documentation or for practicing anything. If a doctor or a nursing staff, if they follow some, that is deemed as, that is a standard. That's how the present scenario is across various hospitals that are that are right now, which are functioning in India. But there is a strive for all these. It is a very diverse environment, because at the PHCs, it's a different scenario. You will not be treating all sorts of cases. If you come to the district level hospitals, there are different ways. Same way in the state level hospitals. You may not get a similar type of care everywhere. And the most important thing where we can, if you want to bring a change, is the change in the attitude of the people who are working. And that is the most difficult thing, what I personally feel it will be there across various cadres, irrespective of whether they are doctors or nursing staff or other staff who are working in the public health hospital. So basically, it is mainly that there is no standardization as such, which is being followed everywhere, and subsequently, the data collection, all those things which can make us to go back to what we were and what we should be in the future.
Thank you very much. So a very important aspect that has been brought out by Dr. Arvind is the need for data and the need for standardization. So that makes it very easy for me. For the next person that I would like to bring here is Dr. Kochar, because he looks after standardizing the care. So taking it from Dr. Arvind to Dr. Kochar, so what do you think, Dr. Kochar, now that you head and you are in a position of being the CEO of one of the most respected accrediting agencies or company, which is NABH. And as I said, it is something which is talked about almost like a home word in most of the people. So what do you think is the way that we will be able to help, like what Dr. Arvind has said in terms of standardization? What is the vision of NABH?
Yeah, thank you, ma'am. So thank you all. Good afternoon. And thank you. It's indeed a great privilege for me to be here. That is one. And it's a great privilege also to be representing NABH, the organization we all love, or rather love to hate, howsoever you take it. But the point is, whether you love it or hate it, it's a necessity. And since 2005, so it's the very concept of healthcare quality in India is very nascent. While JCI came about 1951, ACHS came about 44 years ago. We are just 18 years old, into the 18th year rather. So we have had our share of acne and mumbling and, mood temperaments. So we are still finding our feet. But having said that, we enjoy the legacy and a very rich tradition. And today we are touching about 20,000 plus hospitals in India. But that's not enough. That is one thing. The other thing is that over the past 18 years, slowly, steadily over the programs, we have had realizations that one size does not fit all in this country. We just could not manage with only the accreditation program. So we launched the HOPE program. HOPE is ASHA, it's an acronym, Hospital Online Platform for Entry-Level Certification. So that's a entry-level certification, no other country has that. So there we are adding 250 hospitals every day, which are still learning the ropes and tricks of quality, what exactly. So it's a very basic program for them that is required. So that was launched in 2014. So over the past 7 years, now we have added 12,500 hospitals under that program also. So two facts. One, that the very foundation of quality in healthcare in India is based on NABH, because NABH came about in 2005. But you asked what next? So we have started, our hospitals are cutting edge technology. Now we have to take quality to the last in the line. As Dr. Arvind said, private healthcare occupies 85%, but majority of patients go to public funded facilities. That is also changing, that quality norms are changing. And another fact of the matter is that India is a federal country. It's a big country, lots of population, lot of land mass, and it's actually not one country, but 36 countries rolled into one. The entire population of Australia, that's a question. Anyone? What is the entire population of Australia? For the gift hamper? No. Any guesses? 2.56 crore. Just 2.56 crore, you can check it, of the entire population of Australia. And what is the population of state of UP? 20 crores plus. What is the entire population of Canada? 2.2 CR. Just 2.C, and Delhi NCR is bigger than that. So point here is that we are a very big country, and we have to take, if we are to succeed in patient safety or whatever in healthcare quality, we have to take quality to the last in the line. How are we doing that? Hope has achieved a little bit, but now we have to reach to the grassroots, to the villages. So we have started a program called Sarpanch Samvad. Each of these villages are headed by a Sarpanch, and these are very, please do not go by the word, they are very qualified people. Most of them are foreign educated. They rose from that son of the soil or daughter of the soil, and they went abroad, learned, and now they've come back to serve the country. So these people we have attempting to bring them all on a network, and healthcare standardization, SOP, we are pushing through that. So that is just one solution, but we'll continue.
Thank you. Thank you very much. I think a large part of things that was raised as a concern by our first speaker, Dr. Arvind, has been beautifully summarized as to, and it is mind-boggling, that's a huge country, and still we are trying our level best to reach to the last person who is going to touch the life of our patient. Having talked about at what happens at the public level and how we are trying at all levels, at the crux and the pivotal role that is played in healthcare delivery, all of you will agree with me, that person happens to be the clinician. That this clinician across, whether it is your smallest of your nursing home to the largest of your corporate hospital, is always an individual. And therefore, let's look at from Dr. Basu, who is going to tell us from a single clinician perspective across all of these, what is it that the clinician is going to be, from his perspective, challenges in the patient safety implementation, small hospitals, large hospital, corporate, government institutions. We would like to listen from you from a clinician's perspective.
Thank you very much, and I must thank the organizers for having invited me to this very important session. Role of public entities in shaping the future of patient safety. And in fact, if you look at the entire panel, I'm the odd person out because I'm a clinician, and I must admit and admire that all the work that our colleagues, which have, including the government, and the CEOs and the IT personnel, all of them are putting a lot of work with a common goal of improving patient safety. However, there are certain things which I feel as a clinician can help further. One of them, as Dr. Malti in her introductory talk, she was mentioning about working in silos. And that, I think, is the biggest drawback from a clinician's point of view. Why? Because you see, first of all, we have a variegated, it has already been highlighted, I won't repeat that you have all kinds of people at various healthcare. Whether we like it or not, whether the clinicians like it or not, or whether anybody else likes it or not, the clinicians become the face of an organization. Anything that goes wrong, clinician faces the wrath of the patient. The management comes much later. It's when they are not satisfied, they've abused you, they've said everything else, and then they say, tell us where the management is. I'm going to go up there. So the clinicians face this, and that is somewhere we have to decide that there should be an alignment between the policies of the management and the clinicians. They should be in tandem. Usually what happens is that clinicians are expected to know their subject. They are placed in a position. Okay, so you are a clinician and you are going to be delivering this care. We don't always know what the management's goal is. What are they working for? Is it profit? Are they working for really helping people? Or they, of course, want a good name. Everybody wants, to do the best for the patient. And in fact, so many private entities have come up only with the idea that the government was not able to, cope with everything else. And so they have come up and they are coping. And many of the people, even who were going to the government, are now coming to the private sector. And I think this goes collectively because the management, the people at the back end, the doctors are working towards. However, there is always a gap between the understanding, and she mentioned the word silos, which I was also going to mention. The silos, why do I call silos? The IT people are developing their own programs. The nursing staff is developing their own systems. The others are developing their own systems without talking to each other. Now, if the nursing staff is developing a program, then I think it should be worthwhile that you include the clinicians so they get their perspective in when they are designing any kind of program. At the same time, when the IT people are, and this is a big thing, IT is growing at a much faster rate than, medical science. And the medical science and legal science is, trailing far behind the progress that the IT is making. And so the IT people develop a program, the clinicians are just informed that this is the latest thing that we are going to use, and this has this benefit, this benefit. Poor many of the senior ones, they don't even understand the IT details properly. So I think they should also be taken into consultation when you are designing any of these programs, whether it is for the nursing or anything. Take them on board. Most of the corporate hospitals do have a board which they call the Hospital Management Executive Board, but many of these may quite often not be discussed. It's regarding something else or maybe some issues. So I think first of all, alignment. Create a culture of patient safety, and it should be inculcated right from the, many hospitals, for example, our hospital also has an introduction period of 2 days whereby, whether it's a consultant or anybody are introduced into anything, but I think it should become more uniform, and people should, and of course, communication within the system, and then comes communication with the outside world as well. So I think...
Thank you very much. So we started in the first round where we wanted to understand the current scenario or what is the status, and we got a perspective from NIMHANS where Dr. Arvind talked about it. We went on to get it from the accreditation perspective and then the clinician. Now, the second round that I begin, I would like to first start again with Dr. Arvind. You have said that there are challenges. This is the current scenario. You talked about your data analytics and not being available and various factors. What I would like to now understand from you, if you were given the reins of power from a government perspective and say that, what would you like to do for this country to sort out this problem in our government and public institutions? Would you be able to prioritize and enumerate maybe 3 or 5 things which you feel is going to make a difference in our public institution? Because that's where our patients generally go. So what would they be?
Ma'am, it's like whether we like it or not, it's a mandate of the government. We need to follow few norms. And that has been put forth through a miniature, I can tell, NABH through Kayakalpa scheme. Kayakalpa scheme was envisaged by this government somewhere around 2015, and subsequent to that, they started with the PHCs, then urban health centers, and later on they included all the medical colleges. So this happened somewhere in 2017. The letter came from the government, the communication. I think nobody took it seriously. But we took it seriously when the letter came, somebody is coming to review that. So that is how it is happening to the PHC level. There are norms that are set by the through the Kayakalpa scheme. Government is very, very serious about that, and they are persisting it. What it does is, it is looking at the hospital upkeep to make it more patient friendly. They are looking at what are all the parallel ancillary services, how it is being. There are guidelines that are put forth, for the CSST, for the running of a laundry system, and also the microbial management for the ICUs and all. They are stipulated norms, like how the NABH has got objective elements. Similarly, for this to manage all these things, there are objective elements that are put forth. Even to look at the elimination also, there are norms that has to be followed by a hospital. So there are norms. Whether we are following it or not, that is where the audit is happening. The audit is happening at 3 levels. One, internal audit has to happen, and we need to report to the ministry. And then there is a peer audit that happens. The peer audit means something like an institute of my scale. From the other institutes, they come and observe. They look at. They're all public health personnel who come and do that. And they do that audit. They give the recommendations to us. You need to improve upon this. And the third thing is the real audit that happens from the ministry personnel who goes through each of the objective elements that are framed. It happens every year. So that's how I told prior to 2016 we were different and later we are different. So the same thing, it's not just NIMHANS, it is being followed in every institute up to the PHC level. Initially when it started with 17 PHCs. Today around 15,000 PHCs are enrolled under Kayakalpa scheme. There it is not only issuing the guidelines but also giving the necessary solutions for that, either through monetary benefits or through the personal or various other ways. They are enforcing this, and that is going to be the order of the day in the future. So that the people, if it's just always I tell, if given a chance, the better experienced people will be there in the government setup. But people don't go much, but because their mindset is that if we go to the private entities and all, they will get a better care. So, but if these things are taken care, definitely in the future, the public health system will become more and more robust. We have proved that during the COVID. It is going to be proven even for the day-to-day activities.
Thank you, Dr. Arvind. That was really encouraging, and I'm sure all of you will be very happy to see the numbers of initiatives that have been taken, because as he brought out the PHCs, the place where a large number of our populations even now go to, and there used to be, even when I was a medical student and posted in a PHC, I used to first go and stand there, and there used to be nobody there, because there were no facilities there. And then we were supposed to be trained. I said, with whom are we supposed to be trained? They said, we'll call someone before you finish your postings here. And the posting was 15 days. And on the 12th day, there appeared one human being from there and said, I'm in charge of the PHC. So that was the stage. And if you really now see, there is phenomenal change that has happened. You have all your PHCs manned and they are strict. There are such regulations that if you do not appear there, there is immediately a memo that is sent and they are all penalized. So that's how I think things have taken a great shape from there. Now, having said that, what happens on the public side? I have a question to you, Dr. Kochar. You had talked about accreditation. You have different levels to make it easier for smaller hospitals. Again and again, for the audience, I always come back to smaller hospitals, smaller PHCs, because that's where most of my, I think, countrymen go to. So again, the question is, I've always heard, as a person who's been in the accreditation, a part of the NABH, that hospitals who have got the SHCO or who have got the entry level, which is very good because it's given an opportunity for hospitals to get accreditation. But the fact still remains that they say from this level for us to go to the next level is one of our biggest challenges. We are not able to proceed beyond the entry level. So what would your concern be, or I would put it as, what would your advice be? When do you think that each one of these someday will go from an entry level to the next level? Is there a hope? Thank you.
So thank you so much, ma'am. Initially, I would like to echo what Dr. Arvind said, what you mentioned, that the times are changing. So there's lots of excitement in the Indian healthcare industry, which is positive. And just to give you a very rough example, at NABH also we are seeing this renewed accountability from the public sector. Of the 22 aims, 19 aims are today applicant with us. There are more than 150 fully accredited big hospitals which are part of the NABH framework now. Safdarjung Hospital in New Delhi, 3,500 beds with a medical college attached. RML Hospital with Atal Bihari Vajpayee Hospital, again partnering with us. AIMS New Delhi, since it's too big, trauma center, mother and child health, birth set, there are already accredited facilities. So, NIMHANS is a fully accredited facilities and their
And
own
it's a
team.
big challenge. Knowing
Yeah.
NIMHANS in Bangalore, I don't know how many of you
Yes, and-
would have visited. Phenomenal,
Yeah.
phenomenal.
So no, Max is a private driven,
Yeah.
but NIMHANS is a public facility. So that was the focus which we saw during COVID with entire team led from the top and with involvement of the guard at the gate. They were totally came together to get the accreditation from NIMHANS. Very, very credible experience for us. So things are changing, things are very positive. Now what next for us? So we realize that, and I just mentioned it in the previous session also, that now it's a duty of the bigger hospitals to mentor the smaller ones. Because it's a big country, we have always had a federal structure. Health has always been a state subject under the constitution. So there are some states which do phenomenally well and some states which do not perform as well. So state of Gujarat, Rajasthan, Kerala, Karnataka, they are very progressive states. Rajasthan, so there even the PHC, CHC, the medical colleges under, let's say, GMERS, they all accredited certified facilities. While some things are a little laid back. But anyway, the point is that now that is also changing. Under the PMJ, there are 150,000 health and wellness centers, of which, for example, there are 12,500 under the Ministry of Ayush. So which is integrated care. So these health and wellness centers have recently been named as Ayushman Arogya Mandirs. So of them also, NABH has been entrusted with 2,000 of such centers, which we have to go, do the capacity building, raise their level and give them entry level certification. We have already finished 1,250 of those smaller units and given the certificate to 402 of those. So, which is a big movement happening across the country. So probably COVID pushed it to it was always there in the wings, it has come front and center. Second is how to leverage technology, how to show the benefits of quality to everyone. So that is also happening. ABPMJ is there, ABDM is there. So all these policies which were practically non-existent, now the time has come to bring all of those together. The third is I think the biggest part is staff safety. Like you mentioned, clinicians. So all these accreditation standards, whether they are NABH or JCI or ACHS, they are just tools for improvement. And they have to be followed in letter and spirit. NABH has 10 chapters. First 5 are patient-centric. Next 5 are manager-centric, facility-centric. So next 5, madam, they comprehensively address communication, role of management, role of technology, and how to bring together everyone. Clinicians are a very important part. So how to bring everyone together and have a common goal. So that is the bottom line, that there's lots of positivity, optimism for future, and accreditation as a tool is a very important tool, and these standards also have to change to keep up with the times.
Thank you. Thank you very much. And I'm sure the audience here must be feeling very nice on the number of programs that he has enumerated, because very rarely we get to know all of them. Since he's a person who is responsible for initiating, implementing, we are able to understand that there is so much of good work. And in particular, I take the very important point of what he called as mentoring. I think that is something that we should really look at, because otherwise each of the bigger hospitals is happy with their own accreditation, but we do not actually take another buddy along with us and make sure that probably in a territory we should have a large hospital which should say that I'm going to have this one as my buddy, trying to help them. Sometimes it's just facilitation and helping a smaller one. And I think that was a very nice concept that you had brought up.
We have started a pilot with AHPI also in state of Gujarat again. We will be funding the bigger accredited facilities to adopt 8 hospitals. It's a hub and spoke model, to be a mentor
Fantastic.
for 8 models and bring their level up.
I think that's probably the movement that can begin, because responsibility of having the hub and spoke, a big hospital takes say 5 or 10 hospitals. You can imagine how many hospitals will get enrooted.
Thank you very much. Thank you. So coming back to you, Dr. Basu, I come back to you once again to understand where you talked about the clinicians, their role, and the various problems that are there. So can you give at least about, as again I put the question like I put to Dr. Arvind, to tell that you, as a very empowered lady, is asked now that what would you do to get these clinicians. It's a big transformational change that is required. It is easier to implement things, but when it comes to behavior, I think it's very, very difficult. So what do you think has to be the change in the clinicians if patient safety is the only goal that you want to achieve? How would you want to get it done with your clinicians?
Thank you very much for the question. And I'm actually, all the points that you people have highlighted, I feel very happy and proud that the country, and you said since 2015, things have moved in a very positive direction. And the reason why I'm proud and happy, because I'm the older sister who was the health minister then. And there were very in-house, in-depth discussions. And there are several doctors in the family who would keep on saying that this should happen, this should happen, this is wrong, this is wrong. So he would say, he would listen, and he said, okay, let's see how we can go about doing all those things. So JP Nadda was the health minister at that time. So starting the mother and child tracking system, whether it is the other things. So we all were, somehow we feel we have contributed to that as well. But coming back to the problem that the moderator, Dr. Malati, has asked, how can the clinicians be brought on board? First of all, sometimes I think, and I'm not speaking for myself, I have been, I speak when I feel that, things have to be spoken about. And there are many clinicians, there are different personalities who just never come up with their problems. And nobody wants to listen, especially in the public sector. We are talking about public entities, so I'm not going to address this to the corporate hospitals as such. In the public hospitals, what happens, they are also facing a crux of shortage of staff. And there is severe burnout. The answering, the documentation and everything, and staffing is not increased. This happens everywhere. Even in corporates, they are sometimes compromised. And that the burden is borne by the clinician because he's the one who's answerable. He cannot leave the patient because he generally wants to do a good thing by the patient. So you still take them on, and I think the best part is that clinicians in India so far are working individually. The reason being, I have this protocol, I think in my experience this works, and in my experience this works. Getting them to follow guidelines becomes a major challenge because they think, why should we do this? But anyway, people are beginning to get aware and they are beginning to change. In the public entity, of course, the government is after them. They are answerable every day. And they have, some of my colleagues say that who are in charge of the RTI, every day they have, a big pile of RTIs to be answered by the patients. So I think another important aspect is including the patient's attitude and what they feel, what they want. So we have to address patient advocacy and patient involvement also. We do that, in terms of feedback, but the feedback can sometimes be very emotional. It is not actually a genuine feedback because there is a way of giving a feedback. The patient's feedback is quite often emotion-laden. That, my patient, nobody has answered, I've been ringing the bell, and then the whole hospital at a straight line, they didn't expect this is wrong, and everything. I will talk social media. We are really very, very paranoid about the social media, and yet we don't know that is adding to the burnout of the clinicians. Because patients, what they do is that immediately, they have a cough. I'll confine myself to myself in the obs and gynae. They have a little, I'm not feeling well today, ring up the doctor. Somebody has come up to visit them, they ring up, and this is a genuine question. Do you think it is safe to take iron and calcium during pregnancy? The question never cropped up. You have to explain. Now, how far can you go on explaining to the patient? You may be in the OT, you can tell them that, look, I'm operating, can you ring up later, or I'll get back to you as soon as I'm free. Nahi, 1 minute, aap meri baat sun lijiye pehle. This is how the patients behave. Now, these patients are the ones who, if you don't answer, there was a pediatrician who the complaint went up right to the government. And I'm talking about examples just to highlight how we get stressed. Now, this pediatrician was on leave. The person who was coming to them for, regular checkups, otherwise the child, this child had a problem, vomiting ho gaya, jo bhi ho gaya. She rang up. This pediatrician answered and said, ki, you go to the hospital, to the emergency, I will inform them and somebody will come and see. आप दिखाते हैं, आप हमको जवाब दीजिए. तो उसने कहा कि नहीं, हम कैसे अभी जवाब दे सकते हैं, मैं छुट्टी पर हूँ. छुट्टी पर है तो क्या है, मैंने आपको बोला है. तो उसने कहा कि नहीं, प्लीज़ आप चले जाइए, वहाँ पर आपका केयर हो जाएगी. Now when she came to, whether she went or not, by evening that patient had put in a complaint. And she said that my doctor refused to talk to me, and she said कि I sent her another WhatsApp around 11 a.m. and she had not responded until 9 p.m. Now, this is a practical, what the examples I'm giving are first-hand examples which people have, narrated. Do we address them? And how do we address them? That is where the SOPs will come. That is where the patient education and literacy will come. That the hospital is not open, the doctor cannot be present, your doctor 365 days, 24 hours. This is adding to the burnout because this is where the corporate is suffering. Because an obstetrician cannot be 365 days and 24 hours available, and the patients don't want to go. So anyway, this is one thing. Burnout is important, and we need to involve the patients. There should be a proper handover and everything, which NABH and all the others, you people are working and addressing it, and we keep on hammering it. I think these are some of the facts that the clinicians, what they can do is get there. In the corporate, but we don't have a head system, somebody is in the head. Wherever there is, the system runs more smoothly. But if everybody is an individual, you cannot tell your colleague, you please follow this or anything. So this is something also we need to address.
That was a very, very practical way because of a practicing clinician giving the details. For the want of time, in the last round, my sincere request to my panelists would be to give me, Dr. Arvind, from you. I'm going to end the session by saying we had a sort of a roadmap. We talked about the current scenario from a public perspective, accreditation perspective, clinician perspective. The second round was basically looking at what has been implemented, which was very encouraging. And now the last round, I would like to ask the panelists, if I were to say, just give me 2 challenges. We will restrict to 2 challenges because of the want of time, because I would like to end the session with, if possible, at least 1 question that we'll have from the audience. So to you, Dr. Arvind, if there is just 2 challenges that you can say, there might be many that I can understand from a public entity perspective, just 2 challenges, if you can enumerate, it would be great for the audience to know.
One, the policymakers or the administrators who actually implement these programs, they should be aware of. So that is where we are lacking. I think recently you might have heard or read in the newspaper, the health administrators from the state of Karnataka, 10 people are being given MBA course. They have taken up the MBA course in IIM Bengaluru. So that's where the quality, because they can enforce, they will understand what exactly is the scenario that we need to implement, how to implement these strategies. That is the biggest challenge. We don't know what we need to do. One is that. Then the second one, I always I should request the CEO that what we have got with the NABH is the main, it is more of a documentation. There is a chronic cribbing from everybody that we have to document, That, yes, it was a cribbing initially. Now it has become a part of the culture of us. But still, we can improve upon that. What my request would be to the CEO is, we are having various HIMS softwares from various vendors. Why don't you people sit with them and tell that these 650 objective elements should be automatically documented whenever they are putting it. The KPIs and all should come automatically and make it more user-friendly, NABH-friendly, so that all the processes that we follow are standardized.
Thank you. Thank you. This was a very opportunistic time that he used this panel to get his wishes, and I can see the smiles from all the audience. They said, yes, yes, that's what we want. Thank you for that. And just two challenges from your side, Dr. Kochar.
So first,
just 2
ma'am, I
points.
would say that health is a federal structure, so that should change. It should be brought into a central, top-driven thing, which should percolate single nation, single standard, single guideline. That should flow, customized, of course, to the size of the facility. If there's a PHC in Bihar or a PHC in Karnataka, they should follow the same rules. Health and education is a corollary. They should be brought into a central thing. Second point is that we are kind of, the quality professionals have to be given their due. Most of them are not paid very well. Most of them are not empowered. You know, if I had my way, no, they all work, but somehow the management, does not give them the due regard. They have come up from the third basement to probably the first basement, but not too high. So they must be given their due and importance. And what Dr. Arvind mentioned, ma'am, that is changing. We are working on assessing, rating and ranking of HIMS, EMR. We'll be giving out, NHA has given developed free HIMS, EMR also. We are working, so digital health, leveraging technology is coming up in a big way. And over the next 5 years, that is the area of focus of the government, of NABH, and that will really help. So documentation, excessive documentation is a myth, but that also will be streamlined very much. So be positive, be hopeful. There's lots of positivity for future.
Yeah, there is a smile on all of them. The last one now to you, madam, in one, if I were to say one strategy that you want to implement for your clinicians, what would it be?
I think I would bring it down to one word: communication. Communication throughout. You see, the communication is between man to machine, machine to man, man to man, and machine to machine. And when you're talking about, the various systems, problem faced in the US also is that everybody has a different EHR, they don't talk, so very difficult to get, So the communication within the system should improve, not only machines, but humans also. Create SOPs that this is how it should be communicated, and we are working on it. National Board of Examinations, we are developing a syllabus. It will be introduced into the teaching in line with the NMC guidelines as well. So communication across the board, communicating with the patients. And health literacy.
Thank you. So, friends, that brings us to the end of the discussion, where we had these esteemed panelists who talked about from a government perspective, from the accreditation, from a clinician perspective. And to conclude this session, I started off with what is the problem and what the government is looking at. And it is interesting for all of you to know that there are 6 strategies, exactly what the panelists talked about. And the first one that the entire government of India is looking at is improving infrastructure, which is very, very important, because when we talk about it, whether it is a PHC to smaller hospitals, as I said, the corporates have their own infrastructure, which is probably sometimes 5-star and 7-star. Patients get intimidated, in fact, when they see and look at it like a hotel. I'm talking about the realm of the people who look at it. So they are looking at infrastructure. The second thing, focus of the government of India is on adverse events. They are trying to understand incidents. Are we capturing and encouraging the organization to report incidents? Because incident is an opportunity to improve. And units are scared that if I report, it might be penalized. So they are bringing out a mechanism to ensure it is reported. Number 3, it's very important that the workforce should be competent. You may have a PHC, but if you do not have a competent doctor to take care, so they are spending a lot of money to ensure competent workforce. And the greatest focus of the government is a prevention of hospital-acquired infection. That is strategy number 4. And the 5th one is they are running campaigns. through organizations like the NABH, the government is going to start campaigns of patient safety so that every nook and corner of our country will know what is safe care. And last but not the least, the greatest fund by the government is for research. They believe that we do not focus on research with regard to safety. These are the 6 pillars which have come into vogue, and there's an action plan. It's a beautiful document that when you get an opportunity, all of you should read. It is actually the National Patient Safety Framework document. If you see that, it talks about the country and what they are trying to do, and their goal at the end of the day, friends, we are all here talking today is because we all believe that there is one person who's writhing in pain in the beds of our hospitals. If that person were not to be there, I think most of us would be jobless. So we owe everything to the patient care. With that, I end the session. I would like to thank, and before I end this, yes. Yeah, I'll just finish by saying that I'd like all of you to wait for a few seconds. We'll take this one question, but at the end of it, I'm going to ask one question to the audience. And based upon your answer, I will leave it to all of us here to decide the best answer that you're going to give. And there is a hamper which is waiting here, which will be handed over to the best answer. Yes, so for the want of time, just wait for a few seconds. I know you must be waiting, you must be hungry for that. So let me finish that.
Thank you. So myself, Dr. Praveen sir, working as a district quality consultant. I think in this session, we missed one word, sir, NQAS, National Quality Assurance Standards. So government has started on quality since 1998, sir. They have included all the NABH and JCA, all the standards. After that, they come to know that there are pre-services are not considered in NABH and all. So government facilities, especially for pre-services. So they have summarized all the essence and they have created their own standards. NQS, National Quality Assurance Standards. This is also accredited by the ISQA, sir. So, since sub-center and PSC, all the level hospitals are implementing now that NQS, sir. As you said, each and every sentence is documented, sir. Activities are. So, we are targeting 2,500 facilities within 2025. So, we already crossed on 21% is already national certification, sir. For NABH certification, we have to pay to user. For NQAS certification, government is paying to hospitals. In a district hospital, they are paying 10,000 per functional bed, sir. It is not a small amount in government hospitals.
Yeah. So we are all on, it's a very good point. NQAS is the backbone of the public health infrastructure. There are already 42,000 facilities enrolled there. It is run by NHSRC. It was launched and we work very closely with NHSRC also.
Yes.
See, so Dr. Major General Atul Kotwal ji and the entire team. In fact, yesterday, Dr. Mona Gupta, who's the economist there, we were together. So the entire point here is that whatever you follow, it's a SOP. So
Yes.
NQAS standards are equivalent to entry-level certification for public health. They are very prescriptive standard. For example, it's a checklist-based standard, and it's a very good. Similarly, there is a Ministry of Health and Family Welfare. There is a IPHS standard also,
Yes.
which targets the staffing pattern. Point being that all of this has to come together to create a enabling environment which is good for the patient, good for the staff, good for the facility, and ultimately good for the country. So all of us are together, and these are just tools. Even JCI is a tool. Whatever you choose to adopt, that is there. So no denying that NQAS is a very strong fundamental standard for the country.
Thank you very much for bringing that point, which was also knowledgeable. But for the want of time, I'm sure all of them will be available. And during your lunch, you can always, and it's nice to know that all of you are raising your hands for question, makes me feel good. But let me end the session by one question that I'll put up to all of you, and then we will listen for the answers. The question is very, very simple. I just would like to know, why does a patient choose a particular facility? Because everything that we talked about is patient-centered. I just want to ask you, why does a patient choose a specific facility? What is your answer? We will pick up a few answers, and then We'll find out. Anybody who wants to tell me why? Yes.
Get cured of his problems, what he's come with, and not to get something else unturned. He used to come out without any additional problem.
Your name?
Joan.
And where are you from? Introduce.
Stanley Hospital, I'm the general manager nursing services there.
Yes. Anybody else? Anybody else? Yes, please.
He's looking for probably empathetic care where his problems are understood and then treated rather than just, like a patient number, that this number so and so and just be treated. But I think that empathetic care and the personal touch is what a patient needs.
Okay.
Patient also looks for how safe that particular hospital has been. He Googles adequately about a particular facility. Today, patients are not very far away from the international patient safety goals. They know it actually much better than us. So they kind of figure out how many deaths we've had, how many falls we've had, and if he comes in for a surgery, will he pick up infections with us? So I think he Googles all of this. And although the Google rating is, kind of phasing out, I think he's looking at what patients have spoken about a particular facility, and that's how they get to choose.
Okay. Anybody else? Oh, I want my panelists to be listening to all of them because you're going to get this task now. So we have somebody who talks about safe care, somebody who says that he wants to be diagnosed correctly. We have somebody who says it's empathetic care that is very important. Yes, we'll take two more people.
I would say that it depends on who is the patient. If it's
A patient is a patient. He's sick.
people who are 60 plus, they want a good friend as a doctor. Under 60 want a good Google rating. That's what I would say.
Yes. So I leave to the panelists. You want to listen to two more? Yes.
So very good afternoon. In our country, when a patient is having any problem, he first looks for the name of the doctor. Out of 5 specialists available under one specialty, he will take feedback of which one should I go, Dr. X, Dr. Y, Dr. Z, because of the clinical outcomes. So he will not bother if he's going to a smaller hospital, if that doctor is facilitated in that smaller hospital or a tertiary care hospital, because he knows that the outcome of the clinical practices and with virtue of his experience, it would be best. So in my opinion, it is a clinical outcome a patient would look for.
Okay.
Through the seal of accreditation, which is of NABH.
Okay. We can have someone else.
One more answer, please. All this is secondary. First, patient will see which is nearby hospital. Second, if their relatives or someone got treatment there, then only they'll come.
Okay.
Like word of mouth.
Okay. From in this end, I have not had anybody. Affordability is it. So we have got anybody else still there to, oh my God, there are too many. Yes? You have.
Someone said word of mouth. Would you like to elaborate?
Word of
Mouth.
Suppose if I would have got good treatment there, so I'll go tell my friends. So they will believe on that. That
Yeah.
human thing is more preferable instead of Google rating and all.
So you become the ambassador for that. Yeah, someone I think is going to tell. Yeah.
I was about to say the same points. I think you have already asked the question.
So it is there. So I think you're going to add anything?
Yeah, I'm going to add. I totally believe in word of mouth because Google ratings, we know how it happens. So it's fine. But honestly, if I want to choose personally, because being on the other side of it also, I always like to prefer what was your opinion on experience inside the hospital. Was it good about a doctor or a facility? So
Let's have the data give us the answer. So there have been many studies regarding that, and I'm going to quote Malti Madam's study, right? And this study shows that very small, only 10% go for the vicinity, probably 15% go for the Google rating, 20% go for the knowledge of the doctor or the credentials of the doctor, either American graduate. Even less go for NABH or anything, it's not recognized. But the maximum people, when they visit a facility, they choose a hospital by word of mouth. So if you agree, ma'am, we'll have this. Please come.
In fact, that was my topic when I presented that in a recent conference.
Yeah, so that was the data I'm quoting.
I said thank you to him because I said you are listening to what I spoke. Because he quoted the figures and it's a great...
Not only listening, I took a photograph of the slide, so I remember the percentage also.
It's a true study.
Yeah,
a very
it's a true study.
validated study that has been done where people
but all those who answered, NABH would like to give them a certificate course which is worth 10,000 rupees free of charge. It's an online self-learning module.
Please put in your names immediately.
Yeah, but only those who answered. Neeta is here, so she, as it is disqualified. So Neeta will take up the names. Give us your emails if you are interested in that. We'll give you that self-learning module, 13 hours certificate course free of charge. But you write the names and the emails if you are interested. Thank you. Wonderful, right? But, yeah, and there's a car inside.
Thank you, everybody. I hope you all enjoyed this session as much I did. Thank you very much, and I thank my panelists for really an enlightening session, keeping it very, very, I should say, energetic. Thank you very much. Thanks a lot. Thank you all from the organizing team. Thank you.
based approach that aims to prevent patients and healthcare workers from being harmed by preventable infections. It plays a crucial role in ensuring patient safety and maintaining the quality of healthcare delivery. To delve into this particular session, we have the moderator for the session, Dr. Ratnamani, Senior Consultant Laboratory Services, Apollo Hospitals, Hyderabad. Madam is the Senior Clinical Microbiologist and Head Department of Microbiology, Director Lab Services, Healthcare Infection Prevention Professional with over 20 years of experience in Apollo Hospitals, Hyderabad, India. I request you to take over the program, ma'am.
Thank you for the kind introduction. So welcome to this very engrossing and absorbing post-lunch session on antimicrobial resistance. And as we all know, it's a global health problem and it's multifaceted. The problem is multifaceted, so the approach also has to be multidisciplinary. So for this session, we have an expert group of speakers and we have 3 eminent speakers for that. And we'll start with the first session with Dr. Raman Sardana. And I think most of us know Dr. Sardana. Winning the IPSC. He has got various awards and one of them is Prashasthi Patra from Government of Delhi for Pulse Polio program, as well as he is also recipient of Scroll of Honor 1995-96, 2020 from Delhi Medical Association. He is part of many government committees and initiatives, including COVID-19 and on the biomedical waste management. So, sir, I request you to start the session.
All of you understand Hindi? Yes. Not a problem. If somebody doesn't understand, sometimes while talking in English, I tend to go back to my mother tongue. So, if you have a problem in understanding certain things, just ask me. I'll repeat it in English. So that's one thing. Second thing is that this might be taking slightly longer and I have already apologized profusely than the slated time. I'll try to finish up. Normally this lecture, wherever I have taken is about 1 hour or so, 50 minutes to 1 hour. But here I would try to curtail in about 20 minutes, 25 minutes. Let me see how best we can do that. The idea of slides is that that everything is in published literature and it is well documented. Also, there are a lot of thoughts which have been given to what has been published and how it is affecting us. Okay, so just tell me the constituents of this. Majorly nursing or doctors also here? Oh, excellent, sir. Quality people? Wow. Otherwise, everyone else from nursing. Excellent. Good. ये चल रहा है सर आपका? Okay. So knowledge is vast. You all know about it. That even if you search Google, there would be certain things which even Google can't fetch you. Am I right? Okay, so every minute it is changing. Every minute it is changing. Somebody or else is publishing something. Somebody is giving an opinion. Somebody is bringing out archives and this talk also. Okay, so it has most of the story is borrowed. Okay, so this is in series of creating, reinforcing community awareness. That is what I believe in firmly. So either we talk and you go back home, I go back home, well done job, okay? Or we must address what is there, try to understand what we can implement, okay? Please understand, none of us is too small to implement a huge task. None of us. We are equally empowered by nature, okay? So this talks about a walkathon which we had in Delhi, and our slogans got a big hit in the press at that time. So many people appreciated. They wanted to know more about antimicrobial resistance and such like things. So now, if you allow me, देखिए, don't get disturbed by any of the comments which I make. Okay, I have my opinion, I have my strong opinions also, and most of it would not be based upon some fiction. No, it's a reality. Okay, two major challenges that we all face, we know that we face on this planet Earth. One is Homo sapiens sapiens. Who are Homo sapiens sapiens? We. The new man, the new human being, okay? Man, woman, don't take it, man means human, okay? So human beings, Homo sapiens sapiens. हम चाहेंगे destroy कर देंगे अर्थ को, कर रहे हैं. We already done that. And rest of the things we'll do it. Mind my words for it. Any wars which happen, anything which they dig holes into the earth's crust, well, that's something they are tunneling through and through. They want to go to the other end, tunneling through and through. वहाँ पे क्या अरे भाई छोड़ो वो planet आपको support कर रहा है, it's supporting you, huh? So keep that in mind. Then antimicrobials and AMR. So one we say is the nature's or the creator's reality, Homo sapiens sapiens. The other is which we are facing is what we have done. Okay? So again, it comes back to Homo sapiens sapiens. But it's a major threat. Antimicrobial resistance is a major threat. I'll tell you when we discuss about the costs. Okay. Any microbiologists here? No. Oh, great. So you know about the universal presence of microbes. You also know that microbes कहीं पे भी किसी भी जगह पे adopt कर लेते हैं. ठीक है ना? किसी जगह को adopt कर लेते हैं और किसी जगह के लिए they will create a niche for themselves. Okay. So they can live in high salt contents. They can go to extreme high temperatures. They can live there, and they can live in extremely low temperatures also. Okay, so that is what microbes are. And microbes means bacteria, viruses, fungi, even organisms like parasites like amoeba or entamoeba and such like things. Okay, fine. I can tell you about Halobacteria salt loving. So Dead Sea में कुछ नहीं मिलता, लेकिन ये मिलता है. Are you getting me? That's the beauty of microbes. Okay. Then this particular Pyrolobus fumarae, it can even sustain a temperature of 113 degrees Fahrenheit, 113 degrees, so close to your sterilization temperatures. Okay. So it survives that. ये है इनका क्या? Power, ताकत. Okay. Let me take you on a factual tour of AMR. ये बहुत साल पहले. You heard of Alexander Fleming? All of you? हाँ, बचपन से ही बता दिया गया था. Okay, fine. So 1945. This was. Do you want? I can throw my voice. There is no problem. You still want the mic? Let's try it without the mic, huh? And maybe we can. If you are not able to hear, just let me know. Okay? Is it alright? There is a danger that people will consume antibiotics too often at too low doses, so that instead of eradicating the microbes, a host of antibiotic-fast organisms, that is the antibiotic-resistant organisms. Today we call them as antimicrobial resistant organisms. They will bleed out and will no longer be able to treat septicemia and pneumonia with the current with penicillin at that time, 1945. So right was this man, visionary, okay? And what happened? You see, some लोग blame करते हैं AMR का बात होती है ना? Everyone talks about India. Everyone talks about India. Antibiotic resistance, antimicrobial resistance, India. They will name a few other countries, Pakistan, other things. Now, please understand, that is the whole point in the first right. You have this paper published in 2009, and then this is a paper in 1994. 1994, carbapenems were not even introduced in India. दूर दूर तक नहीं introduced हुआ. Even then, people have reported the enzymes which cause resistance to carbapenems. You all know, you are familiar with carbapenems? Yes. So, 1992. Right? कॉलम आई दे बेटर है वो मैं कंफ्यूज हो रहा मैं इससे बात करूँ या मुझे Okay, till then, so again, plasmid acquired carbapanimases which were first discovered in Europe in the 1990s, and when the blame wants to be spread, we name it as NDM. None of the enzymes, none of the other mechanisms which were prevalent in either in Europe or in so none of the carbapenemases or any other mechanisms, they were ascribed to any European city or the US cities or Japanese cities. Please understand that. Why singling out? I leave it to all of you. Okay? You know the truth better now. Okay. So let us say antimicrobial resistance, from where does it begin? Survival in nature, हर एक को survive करना है. Everyone has to survive. And microbes, I have told you, they can survive at any difficult position. Any difficult position. Okay? So, survival in nature, and it is an evolutionary process. जितना difficulty बढ़ाते जाएंगे, उतना ज़्यादा वो survive करते हैं. Please understand that this is very typical of microbes. Okay. In humans, it happens all the time in the gut. I'll come to where India lies at fault. Okay. So, it's not that we are without. Okay. So, many microbes are intrinsically resistant. वो क्यों intrinsically resistant है? उनको survival है. वो जब nature में होते हैं तो क्या करना है? वहाँ पे they are finding too many things which want to destroy them. Okay? So they have developed a defense mechanism. Fine. So they are intrinsically, अंदर से ही, genetically, they are resistant to these antimicrobials. Then, अगर threat आता है, किसी भी तरीके का कोई threat आता है, तो क्या करते हैं? Then they do. All of you are able to follow me in Hindi? Is it all right? Not a problem. Who's had a problem? Oh, I am so sorry. So whenever if you just raise your hand and I will try to convert it into English. Not a problem. Okay. So whenever they are facing a threat, they put up an acquired resistance. Either they make some changes in their genetic composition, which is the first one. नया तरीके से, new, de novo, new. Acquisition of resistant genes, या बाहर से किसी से मांग लाते हैं. From anybody in the vicinity who can contribute to their genetic makeup. They just gather those genes from surroundings. Okay? It can be through other microbes. It can be in the environment as such. Okay, fine, perfect. I give you just two examples here. Fungi acting in self-defense. So you have penicillin, you know about how it was discovered, and so Penicillium species, and it acts against bacteria. It acts against bacteria. Okay. Next, cyclosporin A. Anybody from who knows about cyclosporin A? What is cyclosporin A? Nothing? Excellent. So it's an immunosuppressive, and majorly we use it in transplant patients. Okay. So cyclosporin A used for transplant patients, but produced by another fungi, and it acts against insects and nematodes. So again, a place of survival in nature. Are we clear about this? Okay, fine. David Livermore is one person who actually produced one of the finest review of intrinsic resistance way back in 2001. It appeared in JAC, and it was something which has been quoted multiple times. Excellent paper, okay? But it gives us, why I have quoted here, it gives us that many of the bacteria are naturally resistant to certain antimicrobials. Okay? So this is what this table gives. You can see a lot of things. If you want to read more, this is a very good article in the supplement. So you please go ahead and read it. It is an evergreen article. I don't think it's going to die anytime. So thoda aapka wo atak raha kahin, okay. I will also take you to something like coral reefs. Okay, there is a coral Poraitis asteroidis. Just when they started looking at and studying this, it shows the presence of fluoroquinolone resistant genes. It has nothing to do with fluoroquinolone. Corals are in the ocean, and in certain areas, confined to certain areas. So the authors here, they propose that coral harbors special microbiota, which helps in coral, help the corals. Okay, so corals इनको बचाता है. They will save these bacteria and produce fluoroquinolone, so that resistant genes, which are, which help them in surviving these drugs in nature. Okay, so मैं इसमें एक चीज के ऊपर आपका कि दिस इज एंटी फंगल रेजिस्टेंस, सब थेरेप्यूटिक कॉन्सेंट्रेशन और इनएडिक्वेट एक्सपोजर टू एंटी फंगल ड्रग्स कैन ड्राइव रेजिस्टेंस एमर्जेंस. ये सब चीज़ के लिए, यहाँ तो फंगस के लिए लिखा है, बट इट इज़ देयर फॉर ट्रू फॉर every other microbe. Okay. Large scale use of fungicides in agriculture is causing a rapid increase in fungal AMR, and it has got clinical ramifications. Okay, fine. Please understand that antibiotic resistance is ancient. So what happened is, in Beringian permafrost sediment, जैसे you must have seen those avalanche which are, which have occurred. So ऐसे avalanche के अंदर उन्होंने देखा snow clad areas totally, and they could find out that genes encoding for resistance to three things, they were present and were abundant. They were not only search kiya to mil gaya. No, they were in abundance 30,000 years back. So that is what I am saying, that antibiotic resistance is ancient. It is not a new phenomena, but it has been occurring all throughout in nature as a survival way for the microbes. Okay, so this is what it is. दो मिनट और ज़्यादा लूँगा इसका. Okay. So it's a natural phenomena which predates the selection processes by the present antibiotics. दोनों चीज़ें अलग अलग है, वो नेचुरल है, सर्वाइवल है, ये हम क्रिएट कर रहे हैं सर्वाइव करने के लिए. ओके. हाँ सर, यू शुड हैव अ बेटर. ओके, AMR का कॉस्ट है, AMR का कॉस्ट है. नाउ these are various studies which have been done. Review है, एक अच्छा review है, and it talks about anywhere from about $80-90 going up to $88,000 and $150. So that's a huge amount. These are various studies which have quoted that much of amount, but I can. No, this is something which they came out with ultimately. By 2050, AMR can cause up to 10 million global deaths. 10 million deaths just ascribed to AMR per year. And the GDP would go down by, the world GDP would go down by 3.8% just on account of AMR. So that's the pity. That's what it is going to pinch people who look at financial returns. People who look at financial returns should also see this. Okay? Fine. We did a small study in our. Sir, next चला दी आपने उसमें से. Okay. So this was way back about 16 years back or something, 14, 15, 16 years back. So Dr. Hena Rani, now she's a senior consultant at Indraprasth, and she was a student with me at that time, and she did her study there at that moment. So we came to realize that a cost of ESBL producing Enterobacteriaceae infection at that time was 27,000 rupees approximately, more than the cost of what the patient could have incurred otherwise. 27,000 per patient at that time. So आज का आप लगा लीजिए, multiply कर लीजिए उसको, just multiply that over 16 years, how much will the cost be now? Okay? It could be, see, nobody wants to measure death. Nobody wants to measure the discomfort that the relatives get. But still, this is something which, okay. So again, this is a good paper, appeared in Infectious Disease Clinics of North America, 2019. What I need your attention is human, industrial, and agricultural waste. They are also primarily responsible for enhancing the AMR situations. And they say that environment and nature interactions and interplay are many times more intricate, more powerful than what we see in our clinics, okay, or hospitals or healthcare settings. Okay. इसको skip करो. Okay. You know about the biomedical waste? All of you know? How many of you have got STPs in your healthcare settings? What about the rest of the people? Huh? How many people you said? Very few. I saw very few hands. Okay. You are not, don't worry about it. Less than 50% of healthcare in India has. Okay. So, hospital effluent and AMR. Indirectly, patient secretions, excretions, and directly unused discarded medicines, used disinfectants and chemicals. We never give any prominence to unused discarded medicines. I'll come to that. What? Residues of fluoroquinolones, sulfonamides, and tinidazoles seen in hospital effluents in India. There are 2 or 3 good studies, Neelam Taneja, and then a study of Diwan et al. And Mutiar PK and Mittal AK. Very, if you go through the studies, you will come to realize बड़ा मेहनत कर गया, but they put in a lot of labor into it. Okay, so what they come across is that 80 to 85% of antimicrobial residues can be effectively removed if hospital effluent undergoes proper treatment before final disposal. That's why I was asking you, how many of you have got STPs, working STPs in your own units? Please be after your administration. It's a requirement by law. Okay? So, less than half of healthcare units have, fine. Nurses and quality people. Quality people, because you keep on the neck of nurses कि ये itna spend ho raha hai, ये हो रहा है. I'm not saying that you are doing it purposefully, but the managing directors, CEOs of various institutions, they keep on pressurizing you. Disinfectant cost बढ़ गया, ये cost बढ़ गया, वो cost बढ़ गया. And nurses are very happy to use disinfectants. Housekeeping, anybody from housekeeping here? Okay, so once you go back, just be very sure about why do you want to use disinfectant when things can be done with soap and water detergent. Okay, they can be done very well. We'll go about this. Disinfectants make, देखिए इतना सा microbe है, it is not going to have too many things inside its body. It uses the same mechanisms for survival against the antimicrobials, similar type of mechanisms it uses for disinfectants or any other threat. Okay? So, अगर वो antimicrobial, अगर वो disinfectant बहुत use कर रहे हैं, तो it is going to get resistant to those disinfectants being used. It will use the same microorganism to cause resistance against the antimicrobials. Are we clear on this? जितना disinfectant use करेंगे उतना ज़्यादा दिक्कत. Okay. Sir, next कर दे, आप कर दीजिए, इससे अच्छा मैं बोल ही देता हूँ. Damage to. Now, this is something which we must appreciate. I wish we had a single long this thing. Sodium hypochlorite has been noted to produce nearly 900 grams carbon dioxide. वो carbon emission ये सब चीज़ें बातें करते हैं ना आजकल खूब सारा climate change के लिए. So same way, per liter of sodium hypochlorite being used. And this is equivalent to the volume produced by an SUV. I'm not naming that SUV. For traveling 7 kilometers. Okay? Are you getting me? This is not bereft of anything. जहाँ पे use है sodium hypochlorite. Hypo use कर लो, होता ही नहीं होता है. गलत कह रहा हूँ? Am I wrong or right? So, good.
Sorry to interrupt you, sir. Another
Time
5
हो गया,
minutes.
आधा घंटा हो गया.
Yes, sir.
Give me 5 minutes.
Sure.
Okay. So this I have gone through. This I have. Results in various studies, I just quoted one, demonstrate that 100 milligram per liter of sodium hypochlorite could increase disinfectant resistance and antibiotic resistance. Okay. That's not much. 100 grams per liter of sodium hypochlorite. Okay. So, coming to heavy metals, वो आजकल, see, I'm any person from the industry I would welcome to counter me. Anybody, you said some doctors here. Yes. So, on the clinical side or on the administration side or clinical side, sir? So, we used to use Foley's at one point in time. Then, wherever there is a problem, we tend to use silver coated and other devices too, which are silver coated or other metal, heavy metal coated. So, please remember that heavy metals have the same fate as antimicrobials. Same fate. So, if you use heavy metals, जितनी वॉर हुई हैं अभी, इराक ईरान वॉर हुई थी, US इराक वॉर हुई थी, ये अभी जो यूक्रेन वाली वॉर हुई थी, सीरिया वाली वॉर हुई थी, any war which has been there, well, heavy infestation by resistant microbes in areas where there were none or very few. Okay? The reason was they got exposed to the bombshells, which are heavy metals. Okay? And unexploded, exploded both ways, and they had a gala time. So, there is a cross resistance between heavy metals and AMR, similar type of mechanisms which they use. Otherwise, efflux mechanisms, pseudomonas and such like organisms, वो बाहर भेज देते हैं, एंटीमाइक्रोबियल अंदर आता है उसको बाहर भेज देते हैं, ठीक है ना, नहीं काम करने देंगे. So similar type of mechanisms they have used, bacteria or microbes have used against heavy metals too. Okay. तो एक स्टोरी है ट्राइक्लोजान की. I don't know how many of you use triclosan. No? Over? I'm very glad about it. Very glad. So see, have a look at your toothpaste, whether it contains triclosan or not. Don't use that. Okay? Okay. My favorite topic. And that is the reason why I call it as an awareness drive. NSAIDs. Everyone has used this? I just took one from ma'am for my headache. Okay. Statins. I take plenty of them. I think everyone above 50 years in India, 45 years in India starts using statins. Atorvastatin or Rosuva or whatever way it is. Barbiturates, beta-adrenergic, diuretic drugs, H1 antihistaminics, mucolytic agents, proton pump inhibitors, very common. थोड़ा सा भी gastritis or कुछ हो तो list has increased. More than 500 drugs have got antimicrobial action in low dosage or in optimal dosage. But they have an anti. Now, if you are exposing microbes, they are all orally taken. Okay? So, if you are exposing microbes to low doses of antimicrobial effect, and I told you, AMR occurs in humans in the. So what are you doing? You're giving them a ready mixture of everything. Okay? And then we talk about resistance. So unnecessary use of antimicrobials, I have not used that. Sorry. Okay. Cetirizine. So all these things. Even your ginseng and ginseng extracts, they also have antimicrobial properties. वो तो लेते हैं हम strength ये वो old age में अच्छा सा scene है. You ask how many people are on ginseng or ginseng. Okay, vitality and nanotechnologies. Please use technology to the hilt. Technologies are innovated and brought because they have to be used. A lot of efforts go into it, but also think about where you can use them, where you cannot use them. Okay? So, despite this substantial advancement, underexplored area is potential microbial resistance to nanomaterials. Please understand that. Okay? We might talk about drug delivery systems or anything which, devices made up of. But still, this is something which we'll have to think about it. Okay? Oh, bhai. Next कर लीजिए. Urban, semi-urban environments, bacteria or cockroaches. Who is wary of cockroach? कौन डरता है cockroach से? सब डरते हैं. मैं भी डरता हूँ लेकिन for a different reason. They are carriers of typhoid, AMR bacteria. Okay? 40 साल से publication यही है. So they still carry on. Okay. Sir.
5 minutes is all.
Okay.
If you can wrap up.
So urban environment per se has been related to development of AMR. Okay. हाँ, next please. ये वापस लो. हाँ. ये एक पेपर है, अच्छा पेपर है, came up in 2022 gut microbes में, and it talks about combined exposure to non-antibiotic pharmaceutics and antibiotics in the gut synergistically promote development of MDR Escherichia coli. Have a look at this. मैं नहीं कह रहा हूँ. मुझे तो मालूम है क्योंकि वो माइक्रोलॉजी पढ़ पढ़ के दिमाग में डाल दिया ऐसा. नेक्स्ट प्लीज. ओके नेक्स्ट प्लीज. नाउ कम बैक. ये बहुत ज़्यादा डिफेम्ड ऑर्गेनिज्म है, कैनेडा ऑरिस. दिस ऑर्गेनिज्म इज अभी रिसर्च very recent. It places them on climate change. This is a thermally adapted Candida species, okay, which was not there previously. Suddenly has come up in past 12-14 years because of the climate change. Okay. Next, please. Bass-Becking hypothesis. This hypothesis is another good way of, if you want to go about and know more about the environment, how it selects. It says that genes are everywhere. So some should not say that this is present in this or that. Only thing is, it is the selection pressure. If the same selection pressure is given to somewhere else, the same thing would crop up there also. Okay, so that is the Bass-Becking. Very good hypothesis, in fact. Next, please. Mitigation is possible. I'll just Next, please. Ban antibiotics except when livestock are ill. That is in agriculture and sericulture and such like things. So it won't happen. Next, please. You see what happens to Kisan Andolans, no? Political, apolitical, whatever it is. Okay. Identification and developing new antimicrobial drugs are important solution, but is it so? नए drug बनाते जाइए. Each drug discovery takes about 10 to 15 years. We didn't have any new class of antimicrobials for past 24 years after linezolid. Next, please. So this is what happens to linezolid. Just after a few months, 5 patients show resistance to linezolid, a novel antibiotic. 5, that's just a few months after introduction of linezolid. You introduce an antimicrobial and it is going to be devastated by microbes. Next, please. Next, please. So, this is what we keep on doing. Orientation and awareness, whatever it is, do it in your own hospitals, do it for the locality, do it in the group, do it in the in your own city, town, your district, or in the state or in the country. But keep on getting the awareness on. Next, please. Advocacy. Have you ever seen a celeb actually talking about not to use antibiotics? वो हर एड के अंदर आएंगे उसके. मैं ये यूज़ करता हूँ, मैं वो यूज़ करता हूँ. ऑर्थो समथिंग. What ऑर्थो इट इज? दैट पहले जावेद अख्तर आते थे. नाउ somebody else is coming. हाँ सर. हाँ. So ortho oil. Yeah. So same thing. Next, please. Now let's come back. We did a small beginning. All discharged summaries, they carry antibiotic advisory for the people. जो discharge हो रहा है उसको एक छोटी सी पीछे advisory है not to use antimicrobials without prescription. Okay, so that's something. I've given an example. There could be so many things which can be done. Next, please.
Sir, we need to wrap up the session, please.
Okay, next, please. मैंने आपको बताया था 1 घंटा लगता है इसमें. चलिए, next, please. Are you bored? Yes, that is the answer. So they can wait for 10 more minutes.
Then maybe one video will skip.
Next, please. वापस जाइए. वापस जाइए. Strong government action, strong professional and public support. The best thing about it is in public support. You are the public. I am the public. If you keep on asking कि वो कौन कर देगा यहाँ पे, कौन है, who's the chief minister? Shiva Kumar and Sidhu Ramaiya and Sidhu Ramaiya, okay, whatever his name is. So माफी उनसे नाम ना याद रखने के लिए. I hope that he and doesn't stop me from boarding plane back to Delhi. So what I mean to say is, anybody, or you ask Modi Saab or anybody else, they will do whatever they want to do. वो कर देंगे, आपके लिए पॉलिसी बना देंगे, लॉ बना देंगे, everything would be there. But who has to get the law? हम लोगों. We have to see to it that the law is followed. Next, please. So I'll tell you something which we have done. We have published also. Rapid diagnostics use करो, मैडम यूज़ करते हैं, शी विल स्टैंड मी इन गुड स्टेड ऑन दिस, दैट use rapid diagnostics, get the organism as fast as possible, and then be very, very focused in dealing with the organism. Okay? Viruses don't need antimicrobials which are active against bacteria. Definitely. So next please. ऐसे एक और है Malditoff. Please come back on it. Come back. Yeah. So Malditoff Vitec MS. ज़बरदस्त चीज़ है. Within a few minutes, you have the identification of an organism in your hands. Very effective way. And what more do you require? At least empirically you are nearing what is there. No? Instead of broad spectrum, you are narrowing down your spectrum. That is one of the reasons, one of the components of AMSP. Next, please. Okay. Next, please. हमारे यहाँ एक OTC वाला है, एक वो प्रॉब्लम है. If we all promise, we will bash up the chemists who, give antibiotics in your locality without prescription. At least start boycotting them. Bash up means start boycotting them. Don't. Say, first you have the prescriptions in front of you, then we'll see. Don't ask for antimicrobials unnecessary, but we have to start our own way, Next, please. Okay. Heavy metals, जो बैक्टीरिया करता है उसको हम यूज़ कर सकते हैं. हैवी मेटल जहाँ पे डंप होते हैं, डंप भी तो होते हैं काफ़ी सारा. All these biomedical waste, they also get dumped somewhere. There's a lot of heavy metals there. तो वहाँ पे हम आप ऐसा बैक्टीरिया छोड़ सकते हैं which can consume those metals, okay, thrive on those metals. But then again there will be a problem. So it's opening up a Pandora's box. You will be having new antimicrobial resistant mechanisms there. Next, please. One Health approach has been advocated, and great thing about it, one big thing which requires to be seen here, they have made environment as a stakeholder. You cannot make environment as a stakeholder. For the mess that we have created, you cannot blame environment. Okay? So, stakeholders are all in equal proposal. No. You have damaged the environment. You integrate everything with the environment under a single umbrella of environment. Then it will work. But if you make it as a stakeholder, people will keep on doing whatever they want to keep on doing. Okay? Next, please. ये आपको मैंने बताया, disinfectants जितना कम कर सकते हैं कर दिए. Please reduce down the disinfect. Even at your homes, don't underestimate the amount of disinfectants that you are using in the homes. वो हार्पिक डालते हैं. I'm so sorry, I'm naming a brand. Okay, fine. So वो नीले रंग का एक वो डालते हैं आप लोग घर में. So उसको you can stop. There are better ways. You can clean it regularly. Toilet मैं बहुत साफ करता हूँ अपने आप, तो कोई दिक्कत नहीं है ऐसा. Absolutely. So use the knowledge that we have gained over years, thousands of years, hundreds of years. Disinfectants एक टेम्परेचर पे काम करते हैं. उनको उस टेम्परेचर पे काम करने पे वो ऑप्टिमल हो जाते हैं. ऑप्टिमल हो जाते हैं तो कम यूज़ होंगे. Are you getting me? So this type of things you can use very well. So concentration and physical state of disinfectants are positively correlated with the degree of pathogen inactivation. ये ज़रूरी भी है for pathogen inactivation. Next, please. Next, please. Okay. Can reversal, ये सब पूछते हैं मेरे से कि can reversal occur by decreasing antimicrobial usage? इतना सब बोलते हो. When I go to public, they ask me this question. हम बंद कर देते हैं एंटीमाइक्रोबियल यूज, कम कर देते हैं, ओवर द काउंटर हम ख़त्म कर देते हैं. देन व्हाट विल इट? यस, आपके ऊपर कोई एक्स्ट्रा बर्डन बोरी समझते हैं, रैकसैक, वो अगर आप लेके आप चलने का हो तो आप चलोगे या विदाउट इट चलोगे? तो बैक्टीरिया भी के साथ में भी यही है. वो जितना उसका जीनोम मोटा होता जाता है, because acquisition of new genes, he doesn't want to carry until unless it's a method of survival. Exactly. Now you have it. अब मुझे कुछ आगे करने की ज़रूरत नहीं है. So you have got the gist. If it is a method of survival, yes, it will keep on. But if you do not use the antimicrobial, there is an added cost to the bacterial replication, and it doesn't want that. It will shun. I have seen it with gentamicin and amikacin long time back. But then, next please. Next, fitness cost. हाँ, next please. ये कर सकते हैं reduce release of chemical biological pollutants. तो इसको ये मैं कहा था कि STP जो है आपको you have to be very very firm with your bosses. Next please. उसमें नया तरीका भी ला सकते हैं, new type of things. Not only the expensive ways, one can do a lot of things with. Next please. Don't fiddle with nature, please. Don't leave your plastics and everything. Are you into the news for that microplastics being found in the blood circulation? कहाँ से आया वो? It is not being manufactured by nature. No, nature doesn't have any intention of harming us. Okay, are we clear on this? So कोई चीज़ ऐसी छोड़नी नहीं है. Next please. Don't fiddle. Next please. R&D, local R&D करना बड़ा ज़रूरी है. What happened in COVID was lot of local R&D, lot of papers, she will agree to it, lot of papers came up. Okay? So, stop making wars. Yes, lots and lots of people die. Kyun? Why? Why should people die in wars? Why should we make wars at all? Unless it's again a matter of survival. That's something else. But you see, analyze all the wars that have happened. It is not a matter of survival. It is just something else. Greed. G-R-E-E-D. Greed. That's it. So this is not an era of war, as PM Modi just said about 2 years back. Other strategies, there are plenty of those. I would not. I'll stop here. Next, please. जल्दी से कर दीजिए तो मुझे याद आ जाएगा कुछ. Next, please. Next. ये सब government कर रही है. Lot of things have coming up from. Next, please. Action plan. ये वो. एक illogical pockets है. I was talking to you about India. Any urologist amongst your friends, or if you are a practicing urologist, please, for God's sake, stop using ferropenum. Please try to spread this message as wide an audience as possible. ये एक ऐसा एंटीबायोटिक है which was withdrawn by US government in 2006. Okay, next please. Earlier than this. अभी ये बुक के अंदर, टेक्स्ट बुक के अंदर आ गया इंडिया के बारे में. सही है ये. They're right. They're right on, once they are right on this. Orally available, very broad spectrum antimicrobial agent of the Panem group, and gut के अंदर क्या कर सकता है. This is an example. So please start a rebellion. I would expect the Kisan Andolan to take this. Maybe they are more effective. Next, please. Next, please. Next, please. So this is a good one. Please have time, make time for United Nations Environment Pro UNEP 2022. बहुत अच्छा booklet है. Please find time. Read some pages every day. A wonderful booklet. Next, please. Now I leave it to you with the ultimate truth about it. I'm not preaching religion. Please don't take it as it's more of a philosophical situation, which requires that it should be integrated with medicine and with all of us today. So that is what it is. Only one truth, and the rest is a cascade of ever-changing. Today we are talking about this. Tomorrow we'll be talking about something else. Then day after tomorrow something else would come up. It will occupy our generations for ages, okay, till we destroy them. Thank you very much for patient listening. So, I'm very sorry. I can't stop myself on this. This is an awareness drive.
Yeah, absolutely. Yeah, so there is a proverb in Hindi, Atiti Devo Bhava. I extrapolated to here saying that audience is God and audience had wanted to listen to Sir Mo. So we will be scraping the next two video recordings, and I think we'll take, rather than that, question answer sessions, because I could see a lot of connect. So we can allow about 2 questions from the audience. Yeah.
Good evening, sir. This way. Hi, sir. This is Dr. Priyank from HCG. I'm a clinical pharmacologist. What's your take and thought on antibiotic cycling, or rather antimicrobial cycling?
You saw my...
Yeah. I saw just over there.
Yes, that is there.
Yeah.
You're talking about cycling of...
Yes. So currently, sir, I totally agree with whatever. Yep. Yeah.
That's what I was talking to you about, that there is a cost.
Yep.
If bacteria or the microbes, if the microbes find that it is going to threaten their survival, they will, irrespective of cycling, they will keep on.
Absolutely.
It won't have any effect. Okay? 1. 2. Cycling will always be effective if throughout the country, let me put it this way, stops aminoglycosides totally. A group of antimicrobials, or stops carbapenems totally, or stop oxazolidinone totally, that is linezolid. Whatever it is, a group of antimicrobials needs to be stopped altogether over a wide geographical area, then yes, cycling might work. It worked with, that is why I said gentamicin साथ में काम किया.
We saw in colistin 2060s.
Right. So it has, this is what you would see in, if it is a cost at the rate of survival for the microbes, they will never shun. You do whatever cycling you want to do. They will not. Once they have acquired, for survival, they have acquired it.
Thank you.
Good question, sir.
Pleasure.
Yes, ma'am.
Namaste, sir. This is Gayatri
Namaste.
from Apollo Hospitals, Hyderabad. I'm a non-clinical person, but as a curiosity, I want to ask you one question. Because one of the slide, it shows that hypochlorite also is a part of that antimicrobial resistance. So what is the next? Because everywhere we use that...
वो idea मैम उसमें एक ही था. Only one idea. That was tone down the usage. What is necessary has to be done.
Okay.
What is necessary has to be done. But everywhere you start using hypochlorite, everywhere you start doubling the concentration. अभी एक 10% concentration के ऊपर भी हो गया था. There was some regulation which came up on 10%. You don't require that.
Okay.
1% is good enough. Why do you want 10%?
So 1%, yeah. So 1% also, because once, so 1% hypochlorite is effective, because when auditor comes to the labs, then they say, what is the shelf life of 1% hypochlorite in the... Yeah. Because every time we get that question.
We'll talk it offline. I'll tell you what to do with them. So.
Yeah. So I think we will take the question later, because we have one question for the audience and there is also a prize for that. So you can take offline with us. I will be available after that. So question is like, we have all heard about the various aspects of the AMR. And first, let me thank Sir, because he has talked about One Health, how biomedical waste, disinfectants, and even animal use in the veterinary has all led to the development of AMR, and how do we tackle, what are the mitigation strategies. So taking this into view, if any of you from the audience can tell, how do we apply or implement this? Because in theory, it looks very easy, but practically, how do we implement? How do we start an AMR in our hospital settings? What is the first thing which you would like to establish? Anyone? Any of you? And there is a gift for that. Okay.
It's only creating awareness. That's the first thing that we have to do. We have to let everybody know in the healthcare sector that who are directly direct caregivers or indirect caregivers, that what is it. Then only we'll be able to actually, as sir was saying, that you reduce, or if it is not required, you don't use it. So it's the same thing, it echoes that unnecessarily don't go overboard on getting this antimicrobials usage. So it's better that we create an awareness and then we ensure the optimal usage.
We have one. We can ask 2 or 3 people.
I think I'm loud enough, I think.
Okay.
Start. I think in the pharmacy, you kind of stop certain drugs which are called as reserve group of drugs. There are first line and second line drugs for each organism which we are supposed to use. And as sir was telling, there are guidelines which have been given to stop the AMR, or to curtail the use of antimicrobials. So I think always have a check on your pharmacy that what is the consumption from each department and what is happening and which are the group of drugs which they are using. So I think will be the first, that will be the primary information which will be getting over a period of, it is easy, accessibility is easy, where you can easily do that work. And also awareness, creation of awareness is always the first part of the journey, but simultaneously working towards it, this will be easy for us to keep an eye or check on the antibiotic.
Local for local.
Yes.
That is what you are saying.
Okay, I think we have been at AMS for the last 15 years. I think we have barely made a dent in India. And across the world it's the same thing, sir. So there's no point in starting this at Apollo Hyderabad or Apollo Indraprastha. This has to start at Karimnagar, this has to start at Mysore, this has to start at those places. Where you have primary and tertiary care centers, why are we giving meropenem and imipenem and sending patients them to die in ICUs of quaternary hospitals? This should be stopped. Maximum you should only allow those doctors to prescribe first or second line drugs. After that, if they are not able to take care in those ICUs, please refer them. That treatment will be given at the tertiary or quaternary centers. I think we should stop it at the tier 2, tier 3, tier 4 levels, at that level, and then only all of this will be there. This is there in most of Western countries where at a primary center you can't refer certain drugs. Only when it comes to a specialist location, you can use it. Yes, One Health is good, but this has to be at a tiered level as we go up. So I think that is the best way to control antibiotics. Then comes animal control, pesticide and everything else.
Yes.
Okay. If we can reward the doctors, or identify the doctors in each hospital and tell them that, those who prescribe less number of antibiotics will be rewarded every month and identified as a...
That's correct. So I think, sir, your decision, what do you think is the best approach? I think collectively.
Please take over.
Yeah, I think what I felt is the one that where you go and start concentrating on tertiary healthcare centers, especially like clinics and all, maybe more, because at least there is awareness among the bigger hospitals. But maybe tackling those areas might be a better option. That's what is my, I felt that the answer. I think, yes. So you are you. नहीं सर आप आ रहे नहीं सर आप दीजिए सर आप दीजिए
Any of you agree if I say that ईश्वर ने सारी शक्ति महिला के अंदर डाली
100%. Ma'am.
It's your prerogative.
Thank
you so much.
सर आइए सर
Thank you.
Thank you. So,
मैं थोड़ा सा एक वो करूँगा. So you got two very good presentations. So I would suggest that once the session is over, it's over at 4 o'clock.
Yes, sir.
So can we have them for half an hour? If you can come back, well and good. They are very good. They are new concepts and on implementation basis also. One is an excellent speakers. Okay. So only thing is they could not attend. come over and attend this. So about the recordings, please do listen to them. One is on vaccination and AMR. That topic has not been touched much, in fact. So that's something which would be very interesting for all of you, by Dr. Rajesh Bhatia, who was regional director of WHO, Southeast Asian region, and now currently advisor to FAO, Food and Agriculture Organization. So that will be a very interesting thing. Second one is by Dr. Sanjeev Kumar on implementation, who is a wonderful orator and a great understanding of the subject, and also he has implemented that very instrumental in Kerala for actually getting AMSP throughout Kerala and in his own institution. So it will be something, if you can come back at 4 o'clock or wait after the
I think if the organizers, if we can, let us see if that possibility is there. Definitely, or maybe you can share in the link or something in your, so that you can all have a look. You can look at that as. Okay, so maybe if you can come back, if any of you are here still, I think it would be really useful. Yeah, we were looking forward to it. So thank you everyone for being a wonderful audience, and thank you Raman sir for that very, very informative, and I could see the passion in sir, and I'm sure all of us will carry back and start working on it. I know it's not just a magic wand which will do it, but we have to work towards it. So thank you everyone, and I also thank the organizers for giving us this opportunity to be a part of this academic session. Thank you.
Yeah, so we have the next session on culture of safety and high reliability organizations. Go for it. Sir, one photograph, please. Next up, we have a session on culture of safety and high reliability organization. A positive culture exists when employees understand the importance of safety and exhibit positive safety behaviors. A robust safety culture requires aggressive leadership, emphasizing healthy relationships that promote open communication, trust, teamwork, and continuous improvement. To moderate the session today, we have with us Mr. Sriram Iyer. He's the CEO of Apollo Health and Lifestyle Limited. He is an adaptive leader with over 20 years of experience, driven by the belief that navigating today's turbulent times requires forward thinking. With a background in sales and marketing, he has crafted innovative solutions at renowned companies like Coca-Cola, Motorola, Vodafone India, and Bajaj Allianz General Insurance. Welcome you, sir. I would request you to take over the session and introduce the speakers.
Yeah. All the speakers are here. Yeah. Preeti is here, Rika is here, and Radhika, and Rekha Chakraborty and Professor Masam are here. Preeti is here. Who's that? Preeti is there. Rekha is this. We can start with Preeti first, and Rekha and Radhika, and
We didn't get their contact number, so we'll try and get
take it. Fine.
Let
Okay.
us start.
Sure. I'm here. Yeah. So good afternoon, everyone. Should we wait for someone to come in, or I can? We can start. Okay, it's my pleasure to welcome you all to this pivotal session at the 11th International Patient Safety Conference, focusing on culture of safety and high reliability organizations. Right, in the realm of international patient safety, as we gather here today, we recognize that our commitment to patient safety transcends borders, cultures, and all the healthcare systems. Now, patient safety is a language obviously spoken by healthcare professionals worldwide. It's a commitment we make to our patients,
to their families and to each other. And as we engage in these conversations and share insights during this session, let us remember that the lessons learned and the experiences shared here will reverberate across continents, influencing the very fabric of healthcare delivery. Our esteemed panel of speakers today bring in a wealth of knowledge and diverse perspectives to the forefront. We'll hear stories of success, challenges, and innovations that have made a tangible impact on patient safety on the various corners of the globe. I'll encourage each one of you to actively participate, ask questions, and contribute to the collective wisdom that will emerge from our discussions. As we delve into this critical discourse, let us remember that the shared vision of patient safety is a force that unites us. It is a reminder that irrespective of our geographical locations, we are bound by a common purpose, which is to provide high quality healthcare that is not only effective but fundamentally very safe. So without further delay, let's commence this session on culture of safety and high reliability organizations in the international context. I extend my deepest gratitude to our speakers, and I look forward to a session filled with valuable insights, collaborative discussions, and renewed commitment to the highest standards of patient safety. So, let me introduce. I think we have Ms. Radhika has not come. Okay, hi. So, Ms. Radhika, she's the manager clinical and quality systems in Cloud9 Hospitals. We have Ms. Rekha Chakravarti, general manager and regional head quality at Apollo Hospitals. Then Ms. Pritindra Sachdeva, regional head quality, Apollo Hospitals. And we are awaiting another colleague to join us shortly. So we could start with Ms. Pritindra Sachdeva. I think since you had to go, you could start with your session first.
Thank you so much, sir. Good afternoon to everyone. So today we are going to discuss culture of safety, and I'm going to talk about what we have learned, how healthcare has learned from other industries, and what are the cross learnings that we have adapted so far. So a simple analogy before we start. So we look at other industries and we look at healthcare. So in other industries, we have people who are working very hard, working together, and the output there is products and services. While in healthcare, again, we have people working hard, but our output is again people, healthy people, because we produce health. That is our output. This is what makes us different, because we have complex systems that any industry that encompasses a wide range of highly specialized professional groups we have very highly skilled activities which no other industries can compare with us, and we use advanced technologies. We sensitively engage our patients and families throughout the processes. But we do not have any black boxes or flight data recorders as in aviation to capture our errors. Our processes are less specified and less standardized as compared to other industries because we handle very unique and complex individuals. Tom Freston has very immaculately explained innovation to us. The simple definition he's put forward is, innovation is nothing. It is just taking two things that already exist in the universe and putting them together in a new way. So, we as healthcare, we are always surrounded from the outside and pressured from within. The constant change has become very normal for us. We've gone through COVID, we have helped everyone survive and revive. So we are most adaptable and we are most resilient. And here I have some examples, and many more examples to talk of how well we have adapted, how well we have emulated from other industries. I'll take you through each one. So the first and foremost and most famous industry that we have emulated is aviation. So they have given us checklists and cognitive aids, which we all know. The safety checklists and other cognitive aids such as emergency manuals are now a part of our safety culture across hospitals. So they have provided us a set of structured and practical instructions, and very well known, the sign-in process before surgery or during an anesthetic emergency. The next one, Banking has given us personalized services. How to begin with personalized banking? We did that, and now we have come to personalized medicine. So they have, you look at the data processes. They have very high quality data collection tools. They collect additional data from the user interfaces. They analyze this data via algorithms, and this is what we do in personalized medicine also. So both the personalization is actually an understanding of the individual journey and the situation at a particular time, and embed the services into the life moment of the customer. And how personalization has helped in setting up safety and security for us because of greater transparency, improved security, and the personalized opportunities. The next example is transportation energy, transportation engineering and power plant industry. So they have taught us simulation. So look at this, the dynamic simulator training has proven to be an effective way to train control room operators who are responsible for the safe and efficient operation of large power plants. So we get realistic hands-on experience. They allow healthcare, how simulation is helping healthcare, because they allow healthcare practitioners to attain clinical skills through hands-on practices, and they make procedural mistakes and learn from their experiences without the fear of causing any sort of harm to the patient. So a safe environment to learn without making mistakes. So we have a lot of simulation centers coming up across India, across the world for healthcare professionals, be it administration, be it clinical skills enhancements, and we have most complex procedures as in endoscopies and neurosurgeries being simulated in an created environment. And we are, safety is we are enhancing our skills and proficiency through safety without harming anyone. The next one is defense. So we used to have unmanned aerial vehicles during the war times, and then they transformed into military drones. And now we have drones in healthcare who are now helping us to deliver critical supplies and critical medicines across the most far-flung areas and the most difficult terrains. Then we have the restaurants. They have standardization. They have standardized menus, standardized recipes, operational procedures are standardized, and what they have given us in return, efficiency and safety in services. So similarly in our healthcare, we have emulated, consistent protocols, optimized processes that enhance our efficiency, reduce cost, and we are able to have predictable and reliable outcome for our patients. So that's why we started developing pathways and guidelines and protocols. We measure our performance metrics. We have gone in for accreditation and gone in for certification. So all that has contributed to the culture of safety. Last of all, but not the least, is the virtual reality. So the AI and virtual reality is for healthcare. So I have an example here for the visual patient avatar. Lot of research work is still going on to have this visual patient avatar in ICUs to improve information transfer and diagnostic confidence. So the avatar's principles are supposed to enable the process of perception and comprehension of vital signs and installation data. So this will help the nurses and the doctors who are working in the ICUs to perceive the patient risk faster. So possibly leading to better decision making and less cognitive effect is spent for the staff to understand the variation in the patient condition. So they have the potential of integrating diverse medical data into a single user interface for the ease of the staff. And this is because medical personnel are as good as the information that they receive. So at the end, all industries are in healthcare. But we, as in healthcare, we give good health to all industries and all human beings and the entire society at large. Innovation is the way to progress, and innovation is meant for societal benefits. Thank you. Thank you so much.
Thank you so much. So I think, Ms. Pratindra, you have to leave, right? So if there are any specific questions we could take for Ms. Pratindra, then we could move on to the next speaker. Any questions? Okay, so I had one observation. So while you spoke about different industries and innovations and all that, so are there any potential pitfall or challenges that we should be mindful of when we try to adopt practices from other industries?
Obviously, sir, because every time, as we discussed, because all human beings are unique and complex. So that personalization thing that we always have to keep in mind, how well that practice that we have adapted or we plan to do, it has to be tested perfectly for any healthcare system. So then we do not make any errors. So while we say yes, we are very adaptable, but we have to be very safe, and we have to be very, we have to hold back while we implement. So that thing we have to, the safety aspect we always have to keep in mind. So.
All right. So thank you very much. So in case there are no more questions, we now move to the next speaker, Ms. Radhika. She's from Clinical Manager, Clinical and Quality System from Cloud9. And she's going to be talking about building a positive safety culture from the ground up.
Good afternoon, everyone. Slides, please. So building a positive safety culture from the ground up. I would like to start this with a success story of IGL. I hope everyone know about IGL. It's in India Gas Limited. So in the heart of India, in the city of New Delhi, there was a dynamic and growing company called IGL. IGL was a leading provider of natural gas and had a vision not only to fuel the nation, but also to foster a positive safety culture within its organization. The CEO of IGL understood the importance of safety and started the journey of making safety positive culture in her organization by providing or inculcating so many things in process. She started making safety champions recognition program. She implemented trainings for ground level to the top management so that everyone involved in that training programs and foster a culture in the organization of a positive safety thing. So she makes IGL known in India or in Delhi also, which is known for a positive safety culture where all the employees not only safe feel, but have a sense of proud that they are working in an organization which is so much into safety things. So safety culture, we can divide into two, holistic perspective. Safety culture in healthcare encompasses a holistic approach. It revolves around shared values and consistent behavior that prioritize patient safety and staff well-being. We have to inculcate safety culture, and we have to imbibe that in our trainings, values, behavior, as much as we imbibe these values in our daily task, we will be more efficient towards the safety culture in our organization. Few key elements of our safety culture are cultural integration, leadership involvement. This is very important that our leaders should be involved, and they should know the process and protocols, like how they have to go about to make a safety culture, a positive safety culture, so that all employees from the ground level, from the front line, will adopt that. Employees' engagement, continuous improvement, communication, open communication, transparent communication is very important for any positive safety culture. Training and developments, risk management, and recognition and rewards. So empowering ground level initiatives. So this is very important that while making any policies, procedures, we should take inputs from our frontline workers so that we can encourage them and they should have a sense of ownership that they are also involved and they are also taken care of. And they should know that they are working in a positive safety culture organization. Leadership roles in setting the tone is very crucial part of any positive safety culture. If leaders play a crucial role in setting the tone of a positive safety culture through their actions and decisions. Frontline workers always see their leaders, their top management. If they are accepted and adopted all the positive safety culture, all the policies and protocols related to safety, then they will also feel very positive that they should also go for the same thing. Transparent communication. Establishing transparent communication channels to disseminate safety-related information from top management. It should be very clear to everyone that any crucial statement or any safety-related concern they like frontline or ground staff can raise to them. Everything is welcomed. Employees' engagement, definitely engagement of all level employee in safety culture is very important. If we engage all the safety related protocols in our behavior, in our daily tasks, then we will become ambassador for safety and we can encourage our colleagues to imbibe the same thing in their behavior as well. So safety is not only one person driven culture, it should be imbibed in everyone's daily task and their behavior. Promoting reporting culture, creating a culture that encourages the reporting system concerned without fear or of reprisal. That is what I just have spoken, that it should be very clear communication. There should be few, like we can introduce mobile apps so that there will be a clear communication or any risk hazard is there, then ground level or anyone from the organization can raise any incident on immediate basis and they can get help on immediate basis. Effective communication strategies, clear channel, establishing clear and accessible channel for reporting concerns and incidents will, like our employees seek help whenever there is any crisis, any safety hazards. So here we can help them. Also, we should always address whenever any feedback we receive from our frontliners or ground level staff, because they are more exposed to any hazard or any risk in the organization. Fostering trust. Fostering a culture of trust among team members through open communication and collaboration. Unless we will not win the trust of our workers in our team, unless we will not show them that we are here to hear you, to listen you, to help you wherever you are stuck, or to help you and to give you all the support to imbibe the safety culture in your daily task. Here are a few strategies to foster trust in safety culture. Leadership transparency, consistent and honest communication, responsive leadership, employee involvement in decision making, fair and just culture, consistency in safety practices, recognition of safe behaviors, training and skill development, employee feedback. We should take feedback from employees on very frequent basis. Consistent enforcement of safety policies. Crisis communication. Whenever there is any crisis, we should be very clear with our staff and we should tell them very clearly that where we have stuck or what is the current situation, so that everyone will be ready to deal with it. Sharing learning opportunities. Leading by examples, leading by success story, to tell them success stories. Employee well-being initiatives. incident reporting and learning. So reporting any incident should be very open culture in any organization until unless any employee from the organization have trust on the leadership that if I am going to report any safety related or risk hazard to the top management, they will definitely hear to us and then they will definitely give some solution to us. Thorough investigation is also very important part of any positive safety culture in any organization. We should do a thorough root cause analysis, and our corrective and preventive action should be like it should prevent any occurrence of any hazard of risk in future as well. Next slide, please. Okay. So we should time to time take surveys and feedbacks, and we should analyze these surveys so that we can plan accordingly in future, like how we can prevent any risk in future. And regular assessment and monitoring also give us safety culture to identify where is the area of improvement. We should always celebrate success. If we have achieved any milestone, then we should always celebrate that. And we should always recognize those employees who have imbibed safety culture in their daily task. We should always acknowledge them. We should always recognize them. We should always celebrate it. Highlighting positive outcomes and improvement results from safety initiatives. So this should also, this kind of activities we should also publish in our organization and in our team. Addressing challenges is very common in building a positive safety culture until unless we will not address any challenge or we will not give trust to our employees that we are ready to face any challenge with their help, with their inputs. Until unless we will not accept any challenge, we will not be able to overcome from that risk. We should always welcome all the innovative ideas, all the from frontline and our from ground up team. Future directions, an organization should always navigate, and tell their team that what is their future plans, how they are going to work for any hazard, what are their plans for any risk identifications. Emphasizing the need of adaptability to navigate the ever-changing healthcare landscape. Thank you so much.
Thank you. Any questions of Ms. Radhika? Anyone?
Hi, Radhika. It was really nice listening to you. I would like to know about your first-hand experience at Cloud9, right? About what do you do differently? What is special about what you do at Cloud9 which makes your organization safe? Something which we all can learn and implement in our hospitals.
Yeah, sure. So what we do, we do regular audits on safety culture from different departments. And this is not only done by quality, it is done by our HR team, by our top management and our operations people. We go and interview and take feedback from ground level, from our doctors to our management team, that how they are finding this culture. Is there anything on which we can improve? Also, we have implemented we have imbibed HERA and MSDS things in our culture.
Sorry, can I carry on with that same question? So Radhika, can you give us an example of anything which when you went to the ground level or did an audit or spoke to a person, you found out something and it was rectified and it was a success and then you shared with others. So would you remember something offhand? Just asking, not just to interrogate, but just to find out if, because we all do all this theory, then it becomes auditing becomes a document, right? Which you just put it in your files. And that, if you want to go beyond that, then what's different what an organization should do?
Okay, so I would like to quote an example of security here. Okay, so like most of the time we did not realize that security is in hot climate of Delhi. They always stand in hot and sunlight. So while interviewing them, we have realized that we should provide some roof or something like that to give them safety from hot, and also time to time we provide drinks to them so that they can work efficiently and effectively in their shift hours.
Wonderful. Thank you, Radhika.
Okay. Thank you. So you can go next. All right. So I think my pleasure to now introduce Professor Narasimhaiah Srinivasaiah, Head of Colorectal Services, Karnataka region for Apollo Hospitals. And he will be sharing on the topic, are surgeons immune to the second victim phenomenon? Thank you, sir.
Very warm good afternoon. Everybody is asleep. Come on, let us wake up. You're in lovely Bangalore, but in a different country, I think. Whitefield is far for us. Good afternoon. I'm Dr. Narasimhaiah. Let us all wake up, take a deep breath in, and listen to something that actually scares a lot of us. The lunch has been delicious. It's Saturday. You all have to get back home. But let us learn one thing that we can take back from this session. How many of us deal with patients here? All of us. How many of us have at some point felt, oops, this was a mistake. I shouldn't have done it. Or, oh gosh, it's happened by error. How many of us? Majority of us. How many of us have had that strength to go back to the patient and say, I'm very sorry, dear, it was my mistake. Please accept my apologies. Tell us how many of us have done it. Very good. How many of us say, I don't know this, let me get John to come and help me? Much less. I think, see, this is the culture of openness, transparency, and patient safety. At the end of the day, we're all human beings. I'm a surgeon, but I'm a human being too. I have a heart, I have a mind, I suffer pain, I go through emotions. I'm a colorectal surgeon. I see deaths, I see leaks, I see infections, I see heart attacks. And what goes through one when there is a death under your nose is very touching. You're not yourself for the next few days. Same thing with you. You put a Venflon in somebody. You've double punctured it. There's a big bruise. There's a hematoma. You've connected TPN to the wrong line. You injected something wrongly. You have pricked somebody 10 times and still couldn't get blood. These are common things we see. Ladies and gentlemen, let me bring you to the concept of victims. Who's the first victim in the process when there is an adverse event? The patient. Who's the second victim here? The clinician, the caregiver who inflicts this. Who's the third victim here? The family. Well done, you. So I think a safe patient is actually a result of a safe doctor. And it is important we concentrate on this. If you actually look at the number of suicides that happen in the world amongst clinicians, it's humongous. Psychiatrists top the list. Anesthetists second them. Not easy. I haven't looked at the data amongst the nursing colleagues, but the amount of stress they go through is phenomenal. And if you actually look at a second victim phenomenon, It is grossly underestimated. Not much of support there. And this is what I'm trying to drive to us all. Committing a mistake is human. Accepting the mistake is divine. And you just need that boldness to go and say, I'm sorry. And that's what we need to inculcate as a culture, both amongst us and the institutions. Something to think about. Look at this. Healthcare practitioners experiencing adverse events as a result of their clinical practice. I think our aim really was to look at, what clinicians feel about this. How many of them have gone through this sort of pain, suffering, and how have they coped with it? So it was a focus group discussion, a perfect research methodology which is underutilized for psychosocial sciences. And we always talk about a quantitative data. Do we talk about a qualitative how you feel? More important is the qualitative data. You can tweak the quantitative data, but it's hard to tweak how you feel. A qualitative research group discussion targeting clinicians who are involved in patient care. Asking them, hey, did you have an adverse event? Did you have a complication? How did you feel? How did you cope? What support did you have? This is all we did. And if you actually look at it, look at this. 90% felt anxious. Imagine I operate in Manipal here, have an adverse event, and then drive from Whitefield to Bangalore, South Bangalore, in this traffic, in anxiety. Not easy. You get more angry. You're screaming at your wife. You're screaming at your kids. You're screaming at your driver. And you will end up doing more mistakes. You scream at your trainees. You scream at your colleagues. Anxiety, not easy. Anxiety, anger actually puts your decision-making process down. Something to think about. Look at the guilt. Was it your mistake? Probably not. No clinician would actually harm a patient. Primum non sere, do no harm first. Otherwise, we wouldn't be doing what we do. There are better ways to make a living, but we are here because of the sheer passion of it, because of the sheer love of it. And we all feel guilty, probably for what is not a mistake of ours. Anger, 50% of them feel the anger. And embarrassment. There is a death on the table today. How do you face the theatre staff tomorrow? How do you face the family? And the worst thing is, you have to do the same operation on somebody tomorrow. How do you get on with it? Smoking, alcohol, these are things people get into to cope with this. Coping mechanisms and strategies are not good. Something we have to think about as a part of what we are doing today, bring in a safety culture. And how do we do it? I think we need to support these people. I think we need to look at how we can put these support systems into play to prevent these things happening. So for those who do this qualitative research, you know how you do look at a grounded theory. How you actually evaluate the data, saturate the data to bring out themes and outcomes. That is what your themes and outcomes are. Look at that. If you look at, the surgeon fitness, a surgeon who's anxious, who's actually fearful of criticism, who's doing a defensive practice, has got a decreased performance on his efficacy and efficiency, who's non-confident, how can he operate? Very difficult. Similarly, you're all nursing colleagues. You draw bloods, you handle central lines. How do you actually cope with it when there's a complication? Very difficult. More importantly, how do your professional colleagues treat you? We're in a capitalistic society. It is a competition-driven profession, at least the private practice in the corporate sector. The person from the ward boy to your clinical head to the CEO talks about a problem if there is a problem. Nobody appreciates you when there's a good thing. But when there's a problem, everybody points at you. A culture which has to change. And penultimately, the society doesn't support you. And this is a true problem. This is a true problem not only for us as professionals, but also for the policymakers. I can't see because the press biopia. Look at this. These are some of the responses from clinicians. One of them says, I can't even talk about it. It'll make me very emotional once again, so that all I have to go is say. So these are doctors, surgeons talking about their adverse effects and what they went through. One of them quit surgery, so to say, and became a GP. This was back in Britain, to say, and I've done some work here as well. I think people underestimate what we go through. It's never been the same, and psychologically that hit me very, very hard, to the point that I thought of leaving this place, and it probably took me a good maybe 3 to 4 months to settle back. Look at this. Not easy. Psychology is not easy. Patient psychology is not easy. Clinician, caregiver psychology is much difficult. But what is important for all of us is to understand that there is a problem, to understand that we need to work on this to bring in better solutions. And actually, these are the challenges. How many of are transparent? How many of us really talk about the duty of candor? When there is a mistake, how many of us go back to the patient and say, boss, I'm sorry, there was a mistake, but we have sorted it out. The duty of candor. How many of us do it? We hardly do it. Something to think about. How many of us seek help? As surgeons, as clinicians, we should all do this. I'm not good at this. Let me go and get trained and come back. I'm not good at this. Let me get a colleague to come and help me out. Let me get somebody to come and watch me do things and correct me. We don't have that culture yet. Something to seriously think about. And support is something we really have to get. And this is what we are trying to do, develop in the Apollo ecosystem now, to look at a second victim support group. Pick up a lay person who has gone through this. Pick up a psychologist who can give us help. Pick up 1 or 2 surgeons who have gone through this. And let us create a support system. If every hospital brings in this culture of transparency, openness, and say once in 2 months, we have a second victim support group, have a cup of tea, go through what has gone on, look at what the weaknesses have been, and a good camaraderie, and that's what you need. And this will be truly a step towards better patient care and a better clinical care. Thank you. Thank you for your attention.
Thank you, Professor Nasamaya. That was excellent. I think let's give him a big applause. So I'm sure we'll have questions here. It's a very topic which is very touchy, and I think he really addressed it very well. So any questions on this? Yes, you want to take the mic?
It's one of my area of interest, actually, second victim. So I have just a small question for you. Do you think that currently we don't have strong laws or acts which would act as a blanket insurance for the second victims, which would help them to come forward and, or do all what we are expecting, go to the patient and be more transparent? So do you think that is the need of the hour? And if yes, so how are we reaching there, or how do we reach there?
See, a tricky question. Here we are mixing medical practice, ethics, probity with medical law. Okay? So, see, India is a big country, but the joy of India is we are rich in diversity. If I tell you the number of clinical practitioners in India who are actually qualified, you'll be shocked. 70% of the practicing clinicians, or what we call as registered medical practitioners, are not doctors. However, if you take out all these 70%, the healthcare in India will just drop down. You go to Rajasthan, you go to Bihar, you go to Uttar Pradesh, you go to the nooks and corners, who's giving care? Not MBBS doctors, not MS surgeons. It is these people, the ASHA workers, the people who have been working and know a bit of a know-how. What we call them as medical practitioners, half of them are not registered. So see, there is a philosophy here, there is an ethical angle to it, and there is a legal angle to it. Even in medicine, though the medical fraternity is fearful of the consequences of medical law doesn't punish people until and unless there has been a mistake, a true conscious mistake. And that is where medico-legal negligence comes into play. And it's very difficult to prove that somebody is negligent until and unless truly there has been a mistake committed. Say, a general surgeon going and doing a CABG, that is, still people are doing it. I'll show you around the town, even in a place like Bangalore, the best of the surgeons are not extremely qualified hands-on people. But what I'm trying to get to is, we can only seek some respite from medical law, but you cannot have a blanket treatment from the medical law. Let us not forget, the medical profession is actually not a service. We have categorized them as service. Vaidyo Narayano Hari said the Indian, tradition, culture, whatever. But actually, India is the most capitalist country in the world today. You get more respect in Britain. There is more a relationship between a patient and a doctor than in India. In India, what happens? You wait for an hour extra, they'll say, Google review, doctor 0 or 1 have been waiting for 2 hours. Come on. They come to the clinic or the hospital and say, sir, thoda discount de do. Do you go and ask for a discount in Starbucks? Do you ask for a discount in Amazon? An engineer who earns lakhs of rupees at 24, 25, they spend their Saturdays and Sundays out on the high streets. How many of us sacrifice our Saturdays and Sundays? How many of us sacrifice our social lives? How many of us have a better quality of life than them? Not many. The problem is, it's the culture. It's the culture we have adapted to. And law is there to protect us, no doubt. But law cannot put a blanket protection. The reason is, there are people to misuse it. So what we have to do is, based on our ethical principles, we should go. See, if you can learn 3 things from this session. 1, if you do a mistake, be bold to say, I'm sorry, I made a mistake. Second thing, if you don't know something, say, I don't know this, can I have some help? Can I get somebody to help me out? And if you learn these 2-3 things, I don't think there'll be any problem. The problem is, we expressing the fear that somebody will actually penalize. Somebody will actually put a punishment across. Absolutely not. And I think this is what transparency blooms from. I do a lot of work on cancer psychology, general psychology. I publish my data on my website. And I call it My Mool. My mistakes you learn. Come on, how many people do it? Here, I've done about 600 procedures, 2 deaths, significant complications in 7 patients. The data is out there with exactly telling what was the root cause analysis. This comes with confidence. This comes with openness. This comes with transparency. Tomorrow somebody questions you, you say, please look at my data. Finish. And it's not difficult. And the best of the families you tie up with are those families with whom you had a complication. And they're your best friends for life. Because the appreciation that they give you is second to none. So it's not about running away. When you do a mistake, you actually say, I'm very sorry, yaar, galti ho gayi, maaf kar do, but we have rectified it. I think this is the thought process you should go with this room, not to fear. And I think that is what I've learned with time to come. It's taken me a lot of time to learn this. And once you've learned it, it's an easy process. And then you start enjoying. That's what I would say. Thank you. Thank you for your attention.
Yeah, fantastic way to put across a system which is not really existent in India. But, the reality is somewhere as bad as what everybody thinks and as good as what you said. We do not have time ecosystem built for doctors or any healthcare workers' mental worries. I'm an ED consultant. I've seen deaths every day, and it's very, very hard to cope. I think what happens in hospitals is you develop your own close group, which is very, very similar to like an AA, right? And trust me, this happens in cafe, among a table where you know who are your agony aunts, and you sit and do. That's the coping mechanism that currently exists. There's no committee. There's no set of people who are going to listen to you. But trust me, we have worked in organizations where even the leadership calls you if you have a loss of life in your department or at your hand. So I would have my group medical director call and say that I heard this happen. You okay? That's all is needed. Most of the times you need somebody to come and say, don't worry, it's all okay. And like you rightly said, accepting your mistakes. We had a situation where we had, by mistake, overdosed morphine, and the patient came for something and ended up getting intubated. The most fearful thing was, how do I go and now say this, you know? So, but like you said, the patient was intubated. Of course, he came out of the tube quite early. We went and just stated the facts. So I had my group medical director right behind me, and we had few security people, because you said in India it's not, in India it's not Vaidyo Narayano Hari. If anything goes wrong, shirt Hari. Okay, they hit you. I've had 4 of my shirts torn. So it's not easy. So we did that. And surprisingly, the patient was very, very open. And he said, well, I'm fine now. I'll go home. But I appreciate that you at least had the decency to come and tell us. And this is not a very well-educated patient or anything. Right? So saying I don't know or I have done a mistake is not a sign of weakness. It's a sign of strength, and better emphasized by you. Thank you.
Thank you, sir.
Just one.
Thank you so much. I just had a question, more of a thought, and if anyone can please help me, is that suppose if there is a complication which can happen, if a surgeon tells me that I don't have complications, he's a liar or a god, so we know that. So if there's a complication and the patient has to undergo another surgery, who pays for the surgery if the patient does not have an insurance cover? It's a hospital to pay, the surgeon to pay, the patient to pay for that money.
In India, unfortunately, insurance sector is reasonably robust in a place like Bangalore.
There's no insurance.
So normally it is put on the patient, but as a clinician, you'll have some leverage to say to the institution, boss, it's a mistake from our side. Can we just waive off all the professional fees and the operating fees and just charge? So the clinicians do have a say, which certainly gets incorporated in the commercial sector.
It happens also. It happens also. In the real life, it happens.
There is no hard and fast rule that they will pay off the entire bill, but they will be reasonable.
So the consumable cost, I believe.
The only worry is on the legal side, discounting your next procedure is seen as an admittance of your mistake.
Exactly, that was my thing.
I know where you're coming from.
Yes.
But unless you do that, but as organizations, like what he said, surgeons give away their charges, hospital gives away whatever the charges, and you still do the second operation. By rule in my last organization, a second surgery can't be charged 100%. It has to be 50%. By rule. Whether it's a complication or not.
So I hold a hat of a medical lawyer too. So I finished my medical law, ethics and law from Bangalore. So see, any complication, if it is documented that it's a possibility that it can happen, medico-legally you're protected. Say you're doing an anterior resection, a bowel resection and a joint, the anastomodic leak on the left side is about 10%. And if this patient falls into the remit of an anastomodic leak, it is considered not as a negligence, but a complication which can potentially happen. So suppose somebody really cuts off something which you should not even come across in an anterior resection, then that is negligence. So I think truly the skill, all these things factor in, but when there is a mistake and a complication happens, the sectors do accommodate, clinicians accommodate, and the cost will be taken care of more often than not. But if there's insurance, they pay. They don't question these things.
Yeah. So thank you so much. I think that was very interesting, and if we didn't have any limitation on time, I'm sure we continued, but unfortunately we have that. So we just have 5 minutes left now. So
This is not done.
No, you ask these folks. I think I am there, but they have told us. So I would request you to just keep the bigger points, and the
I'll
topic
skip all the slides and say thank you. My job is done.
So topic is learning from failures. Is zero harm possible? So.
Right.
Thank you
Over
so
to
much,
you.
everyone. Thanks a lot. Thanks, sir. And thanks a lot, sir, for the insight. Basically, he's our eminent surgeon in Apollo Hospital, Karnataka region. And whatever he spoke about in terms of second victim, the errors and preventable errors and the communication, it is actually, we have seen during his practice from the time I have joined Apollo, sorry. And the second part, what we were talking about, escalating any issue, whether it is due to his team or any other team, and bringing to the level of preparing a root cause analysis is coming out to a positive change in terms of the system or a process, or in order to bring in a change in the outcome. He has been always been very, very instrumental and supportive for us. Thank you very much, sir. I was also thinking probably he's got a little emotional also while talking in terms of the Sundays and the late hours and everything. But that is a fact. That's a fact that we all see across for all the doctors. And because of this noble profession that is around us, we are all safe. Thanks again for that. So to come to my topic, I would only say that we have spoken about errors, we have spoken about the culture, we have spoken about the behavior traits and everything. But what exactly, why do we reach to a level where we have a potential chance of an harm or a potential chance of an error? Can we avoid that? Is it possible to completely mitigate that error? Is it possible? I'm asking this question to myself, I'm asking the question to all of you also. Is it possible? I do not know. I do not have an answer for that right now. But I can only say there can be efforts that we can make to mitigate the error as much as possible and kill that particular potential chance of a near miss to become a sentinel event or a kind of a drastic error which cannot be avoided or that can cause harm to the patient. So a small step if we take at the initial stage, or maybe at that stage where it can be preventable, it makes a lot of difference from all the perspective, from the doctors or the nurses or the health care provider side, as well as from the patient side, as well as the cost involvement, as well as the pressure on the system, and all ecosystems which we're talking about right now. So I think we have to little bit think about a possibility of having an opportunity to see whether we can lead to be in at level where errors can be prevented or cannot be created at all. So when we talk about a culture of safety, we have all spoken about the behavior traits like attitude, the beliefs and values of an organization. So just by having all these values inculcated into our ecosystem or into our hospital culture, probably we bring in a culture of safety, culture of belongingness, culture of transparency, culture of openness, culture of feel-good factor, or the just culture that we talk about. Yes, it makes a lot of impact because many of the organizations who are actually delving into this right now, the people who are working there or even the patients who come to those organizations, they feel they are protected. They feel they have been taken care of. They feel they have been heard of. So that makes a huge difference because they work with free mind. They are not anxious about anything. They are not fearful about anything. And they are open to talk about it, discuss about it, come up with root cause. They themselves give inputs about how to improve on those, and they are the people who implement the corrections which is made after the root cause analysis. So that culture is very, very important in any organization which talks about a safe culture. Then we talk about the environment that we spoke about, that it influences the aspect of healthcare delivery from clinical decision making and preparation of policies and procedures. And also it talks about the ethical impact, as we always spoke about the ethical implications of it. I will not go much into the depth because we already spent 10 minutes on that. So that is definitely impactful on that. So I'll move to the next part. 1 second. So striving to for zero error, as we talked about, what are the 3-4 things that we need to look out for an effort to strive towards creating a zero harm culture? The patient-centered culture, which is very, very important for prioritizing the patient safety and also providing the best care to them so that they feel comfortable, as we spoke already. The ethical imperative, yes, we have understood that very clearly now. The quality improvements that we do, How do we ensure the quality improvement? That also will come into the next slide that we'll talk about. Then fostering trust and confidence. Yes, by implementing all of these things, we definitely build in a trust among every personnel who is involved in the healthcare delivery system, right from the caregiver to the care provider. They feel trusted, they feel the trust, they feel the confidence, they feel the values, and they feel comfortable. The best part is they feel comfortable. And the cost implications. As we spoke about the cost implication right now in great detail, it impacts everybody. Even if the patient pays or the organization pays or the insurer pays, whoever pays the money is additional money which goes from some pocket. Whichever, so we can calculate from where does it go, but it is spent somewhere which could have been prevented, right? Then we talk about the journey to zero harm. How do we ensure a journey to zero harm? So these are attempts. Again, I'm saying could be, could not be. There are things which can be preventable. There are things which cannot be, but attempts is very important to be made. That is the most important catches. We have to make all possible efforts to see that we aim towards zero harm. That should be our objective. So by continuous learning, by enhancing our learning, and also ensuring that we are able to implement certain targeted changes in a system and monitor them and sustain those changes to see that we improve on our processes and ensure any variations as per the clinical practice guidelines or the standard operating procedures that we follow, so that we are able to maintain certain standard of care, and any variation can be easily caught or identified, and corrective measures can be made. Then the root cause analysis, as we said, the underlying concern or an issue or a problem which is leading to these errors have to be easily picked up, and it has to be corrected as early as possible. The evidence-based practices are very important to be checked into, because this actually helps us to protect the system as much as possible, and also the entire patient's care is protected through that. The technology and innovation like the electronic medical records, the AIs that we have spoken in last 1.5 days, we have been talking only about AI. We are talking about decision support systems. We are talking about the new nuances that is coming up in the healthcare delivery system. All of that will definitely help us to be more vigilant and more careful about the delivery systems that we are having currently, and it is visible into everybody's eyes. It cannot be washed away, or it cannot be drawn under a carpet saying that yes, something went wrong, but we do not know what went wrong. Those things will not be anymore, because it will be up and visible to all. Then we talk about staff engagement. I think the speaker from Cloud9 had spoken in great detail about staff engagement. Staff engagement are very important because it really helps them to motivate them, increase their morale, and build in a system where they feel that yes, their personal health is also being taken care of. The mental health is also being taken care of. If we engage them, we make them feel happy, make them feel comfortable, the potential chances of committing errors by the staff is quite less. As we talked about the security person, how he will be taken care of, we can give them offs, we can take care of their small things by talking to them quite often, communicating with them, asking them what are the constraints or issues that we are facing, what can we do to improve on all of these. It is just not related to one department, every person, everybody who is working there hard and continuously without even complaining, we have to reach out to them and ask them, how are you feeling? How are you today? Are you comfortable? Are you in a position to take care of the patients who are lined up for today? If we talk in that way, at least they will say, no, today I have got some family problem, something is bothering me. Can somebody reach out? That is very important, and it is not a kind of a pressure that we have to, as an organization, that we have to reach out to people like that. This should be a culture. This should be a culture that we talk to each other, we discuss with issues also, and try to make them comfortable, find solutions which makes them comfortable and work comfortable with us. Then we talk about, Then we talk about the continuous improvement. So there are certain steps by which we can improve our quality systems. We have heard a lot about the systemic approaches like PDCA, PDSA, Lean, Six Sigma. So these are just not words. These are the tools which has been given for improvement the quality systems. If we implement this well, pick up projects, pick up QIPs on a regular basis for the issues that is coming across to us on a regular basis, we will be able to curtail those issues and we will be able to build up a very, very strong system which is proven that it may protect us from the errors and the harms as much as possible. Then we talk about risk reduction. Now we do potential risk analysis, like what many of us have learned about the technique of doing FMEAs. Why do we have to do FMEAs, failure mode effect analysis? Or why do we have to do a risk charter for each department? Why do we have to do risk scoring? Why do we have to check on a risk score at the end of the year and see what are the inputs that we have put in or what are the preventive measures that we have put in to reduce our risk from maybe from 10 to 5 or 5 to 0 or whatever is the number, and what more can we do to maintain that? How often are we checking on our risks on a daily basis or a weekly basis or a monthly basis to see that the plan that we have made at the beginning of the year, is it sustained? Is it helping us? Is it needs further enhancements, or is it required that we need to put little more effort to reduce the risks in the system? This is like proactive approach to ensure that those errors do not get repeated ever. Then we have engaging frontline staff. Definitely, we spoke a lot about staff engagement. Then cultivating a learning culture. As we said, continuously we have to keep learning, keep understanding the best practices from each other and grow in terms of maintaining and sustaining a good culture of organizational growth. Sustainable improvements. So when we implement a process, we also have to ensure that it is sustained. Otherwise, the entire effort goes for a toss. So in summary, this quality improvement becomes a catalyst that will help us to prevent any harm in the system. Okay. So measuring the progress towards zero harm, these are certain parameters. I'm sure all of us have seen this. We have been measuring this day in, day out, but it is just not the measures. Why these adverse events are happening, why these hospital-acquired infections are happening, why these readmission rates are increasing. Are we actually delving into that, looking at the trends, understanding what needs to be done to improve on all of these and ensure that our compliance percentage for all of these come to a level with a benchmark that we have maintained, international, national, hospital-wide, cross-hospitals, whatever is your way of doing it. Are we looking at those trends and trying to understand whether we are making enough step or enough efforts to bring to our system wherein the compliance to all of these processes make our system a well-sustained and a well quality-driven culture system where errors are preventable and it gets prevented at the beginning of its genesis, I would say. Then leadership role, as Madam was talking about the leadership role also. So when we say about leaders leading by examples, so they have to set the tone. They have to set the tone of culture of in terms of their actions, by their work, by their guidance, and also the support they need to provide to all the employees. They have to be the people who should be the forefront people who should be coming up saying that, yes, we have to maintain the standard of quality or an environment where there's zero harm is something which we have to look at as first priority. And the providing resources and support, yes, it is a very important task. Without resources, without support, it is not going to happen. Then we talk about encouraging innovations and risk-taking, we spoke about it. Recognizing and celebrating learnings, yes, we definitely have to recognize, provide awards and make them feel happy and encouraged to ensure that they are more towards sustaining this culture of safety. Then we have to look at certain case studies like medication error. Kya ho raha hai? Is it going up? Okay. Sorry for this. Okay. So medication error reduction in hospital A. So hospital A has identified several medication errors now, and including instances of incorrect dosages and administration errors leading to patient harm and near misses. So when we look at this kind of errors, don't we feel that these errors can be preventable? Don't we feel? Because we keep on looking at the medication errors left, right, center, and we say that, okay, ठीक है, 20 medication errors have happened. Next month 15 medication errors have happened. And those errors are so, like we can, if I really look at it, there are many ways by which we can prevent those errors. By just being little careful, just being extra vigilant, and when we do the root cause analysis, when we do this process redesign, when we train the staff and we continuously monitor those and ensure that whatever we have implemented as a process correction in the root cause analysis, it is not repeated again. Those errors are not repeated again. Are we making a commitment to ourselves that whatever we have made, creating a root cause analysis for 35, 40 pages, spending 15 days time, and then going back to the same error and saying that, okay, this RCA, whatever we are preparing the same RCA again and again. Does it help anybody? Aren't we in a system where we are not conscious enough of making up a document just for the sake of making it and not implementing it on the ground, or not making a correction which is actually required to be made on the ground? So we have to think from these perspectives, that when we're making a process redesign, when we're talking about a staff training and continuous. Sometimes when we say staff training, the way the training happens is, every document looks pakka, every day, every month, every week, the document says that the staff has been trained. But when we speak to the staff, asking about what are the 3 things that you made as a correction from the error that had happened from the last time till now, there is no answer. So what is the purpose of such training? Has it actually happened on the ground? So we have to be very honest to ourselves, that we talk about zero culture, we talk about just culture, but actually are we trying to implement those culture changes, or we are just talking about it or documenting beautiful this thing, just passing out the accreditation processes? Are we actually looking into it on the ground level? So that is why when we say that the number of errors are not getting reduced or number of errors are continuing to happen, that means there is somebody who is not serious about it in the system. That we need to identify and make correction there. Then we talk about the second one is surgical site infection prevention at Clinic 2. Again, the same issue. When we talk about the high rates of surgical site infections following certain surgical processes, leading to increased patient morbidity, prolonged hospital stay, and additional healthcare cost. The same processes that we take, again, when we find a particular case of a particular nature wherein a hospital-acquired infection has occurred, the 10 things that we have looked into and the process correction that we have tried to make, that has to be sustained. Then the errors will come down for sure. The next one is related to communication breakdown leading to medication errors. Yes, communication breakdown, lack of double checking, lack of consciousness. When we have handovers, half of the documents remain incomplete. We don't even know who signed those documents. You ask the next staff, they will say, yes, we have given handover. But you ask him or her, whom you have given handover, we don't know. Somebody came, or even if they know, they have not done it in a religious manner. In physical, I would say as per policy, they have not done it, or in true sense, they have not done it. The documents are pakka. But actually, if you ask, kya aapne handover kiya tha? Which medicine have you handed over? What was the dose at that time? What was the due dose? They have no idea. So this is the lack of consciousness. This is lack of system failure, that because of which the errors are bound to happen. The night staff and the morning staff, there is no connect. Total disconnect. I don't know what the previous staff did, but I am doing this. What is the consciousness level there? And why don't we think that when this kind of process gap or system gap is there, errors will not happen? We are prepared for that, right? Then why are we talking about zero harm? Very simple, no? Calculations are very simple, but we are not ready to accept those concerns in our own systems. 2 minutes more, please. Then overcoming challenges, common barriers to achieving zero error is the culture and leadership barrier strategies. Now when we talk about the culture of leadership, the resources, the data management, the workforce engagement, and the complexity of healthcare, all of these will have certain barriers to help, not to help us to move forward. But what are we going to do about it? Are we going to sit on it? Or are we going to find a strategy to overcome those barriers and bring in a system which is a sustainable, good quality, just culture quality, and a zero error quality system by implementing those strategies into the system? So by addressing these common barriers and targeted strategies and collaboration, we progress towards achieving zero harm and ensure that the safety of the patients is being maintained. So the last slide, Mukram, the last slide. So the key point summary is basically the importance of measuring progress towards zero harm that we have promised to ourselves, and we will ensure that we will continue to do that. Common barriers in achieving zero harm and strategies to overcome them. We definitely have to think about new strategies, the innovations, and see that those harms are being completely mitigated from our system so that we have the culture of zero harm in our systems. Learning from failures, definitely yes, but when we learn from failures, we also understand or accept that we should not repeat those failures and keep learning that again and again, again and again. Then we talk about identifying underlying issues by doing this RCAs and corrective actions. Then embracing a culture of learning, transparency, and accountability. Everybody should be accountable for the just culture. Everybody should be accountable for creating a culture of zero harm. It is not one person targeting somebody with second victim. The person has became a second victim because of somebody else made a mistake. Why don't we look at that? There are 10 people involved into patient care, but that one person will feel guilty because it has happened due to him or her. So everybody should be equally accountable for that particular error if we are not abiding by the system, or if we are not abiding by the principles that we are actually trying to put it on paper, put it on policies, put it on documents, but when we have to implement, we are just shying away from doing that. Then we talk about the call for action. Yes, the prioritizations of safety is the fundamental aspect of today's world to ensure that the patient outcome and care delivery is safe and they get the best outcome. That is the promise that we will have to make. Fostering a culture of safety, definitely yes. Investment on resources have to be looked into. Quality should not be looked at as a liability. Quality should always looked as a investment because it protects everybody of us, including the organization, including the personnel, including everybody for that matter. Then empowering the staff to actively participate in and identifying and addressing these issues. So this is the gist of the zero culture or the just culture that we have to really build into the system. And as we say, we have to promise ourselves to ensure that we have a system of zero error, and if not zero error, we aim to reach to a zero error. Thank you very much everybody for your patient hearing. Thanks a lot.
Thank you so much. I don't think we have time for questions. So I think before we end, I think just as let's keep reinforcing the culture of safety and building high reliability organizations. Thank you everyone. Thank you for the audience as well. Thank you.
Thank you, everybody. Our valedictory session has already started in the ballroom, the main hall. Please assemble. Yeah, we'll do that.
फोटोग्राफर को लेने दो
हमारा तो हो गया
Yeah, thank you very much.
Thank you so much. Thanks.
Thank you so much.
Just punch your number there.
That's my number.
मन की बात हर ऑडियो में बोलते हैं